Foxy. Um, Today is the first episode of Gyaan Sangam, which is planned by Dr. Bharti Madam, Vidya Madam, and all the KSOGA heads. As the name suggests, it's the amalgamation of knowledge from all the directions of India, so that we all learn new things and make our practice better. So let us start this program with a prayer by invoking God. Arun, please play the prayer.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, Arun. Now I call upon our President, Dr. Madam, who is a dynamic leader and who has made all of us come ahead and work, all young girls. Madam, I request you to give your welcome speech.
Yes. Good afternoon, everyone. We all welcome you to the first episode of Gyaan Sangam, which is a KSOGA initiative, and we plan to connect and collaborate to each state of India with the academics. So this is a fortnightly program with the association with all the committees, all the societies of Foxy, as well as all the states. Today we are doing in association with the Perinatology Committee. Our Dr. Chinmay is there. And I have got a very great pleasure to welcome our President Foxy, Dr. Jaideep Tang. I think he will join shortly. Then we welcome you, sir. And also I welcome our Chief Patron, Dr. M.G. Remet, sir, who is our backbone. Always he will be inspiring us for his presence. In spite of his all busy schedule, he will be always there to guide us. Sir is a patron, chief patron and backbone, as I told, and he's a great inspiration to all of us. Welcome, sir. I also welcome Dr. Alpesh Gandhi. He was my president. He has inspired me in many, many ways. Under his guidance, I brought up Food and Drug Committee, for which I won the Best Committee Award. I welcome you, sir, for this program. I welcome our Vice President Foxy, Dr. Ajay Mane, who is my big brother and always a supporter. He supports, and he's a very vibrant person. He was a past chairperson of Adolescent Committee. Adolescent, he was a chairperson of Sexual Medicine Committee, as I know. So it's a great pleasure to welcome you as well. And it is very great opportunity to interact with various faculties who have joined here. I welcome Dr. Sampat Kumari, our Vice President Foxy, past Vice President Foxy. She is also very close friend of mine. I guide also for many of my program. So welcome Dr. Sampat Kumari. Other faculties who have joined here, and my main own KSOGA family, I must say, Dr. Rajashri, Dr. Bharti, Dr. Rachana, Dr. Mahesh Koregal, and my all EC members, Anta Shekhar have joined. So those who have joined and not joined, and they will be shortly joining. So I welcome you for this is a series of program we are planning that is connect and collaborate. And I must say that Dr. Bharti has taken this time very great initiative for connecting various societies and the academic, whatever sharing we are doing. Maybe we will be bringing out small newsletters out of it, a small write-up, and that will be uploaded on the website. The people who have joined from far and near, I welcome you all, and let us have a great academic discussion. Thank you very much.
Thank you, ma'am.
Thank you. Rachana?
Yes.
Thank you, madam, for your inspirational speech and your blessings. Now I call upon Dr. Bharti Madam to introduce the chief guest, Dr. Jaideep Tang.
Thank you,
Shobha,
Shobha.
just call him. I am not seeing him in this one, so please call
I called him. Dr. Vidya, I called him. He's not picking the call. So probably he will join. So should we do the introduction now or should we do it later on?
No, later on when he joins. So
we can, yeah, because I called him twice. He hasn't picked the call. So I think we can do the introduction. We will move on to introduction of Dr. Alpesh Gandhi and Dr. Ajay Mane.
Okay. Okay. Now I call upon Dr. Rajeshri Madam to introduce our guest of honor, Dr. M.G. Hiremat, sir.
Yeah. For KSOGA program, I don't think there is any need to introduce me.
But
I
there are
myself,
other people. Other people also have joined, sir.
just 1 minute. You can take 1 minute.
Pranam, sir, and hearty
Namaste.
welcome to the program on this evening. And I extend warm welcome to all the dignitaries of Foxy who have joined in. And it gives me a great pleasure to introduce our patron and our guide and our leading force, Dr. Professor M.G. Hiremat, sir, who is now the principal of KLE Kahers, JGMM Medical College, Hubli, the academic council member of Kahers deemed University, Belgavi, former director of Karnataka Institute of Medical Sciences, Hubballi, past president and head of the department of KIMS Hubli, president of Hubli Dharwad OBG Society and KSOGA, chief patron and founder secretary of KSOGA, ex-chairman of the breast committee of Foxy, past vice president of Foxy, CEO Arya Vedanta Scan Center Hubballi, past senate member of Karnataka University Dharwad, past president of Rotary Club of Vidyanagara Hubballi, recipient of the Millennium Fellow Award for Excellence in Academics by Foxy, and Secretary General of Karnataka Medical College Alumni Association Hubli, President of Sri Santeshwara Educational, Religious and Philanthropic Society at Varanasi, and President of Ranga Vaidyaru Cultural Association Hubballi. So apart from academic excellence and administration, we have our chief patron who leads us by example by taking part actively in various facets of life, including the spiritual growth and the arts and culture. Hearty welcome to you, sir.
Thank you. Rajeshri, for nice introduction. I will not take much time because so beautifully organized scientific program. In KSOGA, we had earlier Gnana Harsha, which was only dedicated to postgraduate teaching. Now a new idea has come by our president and also the president-elect, Dr. Bharti, Gnana Sangam. A very nice, wonderful word. And it is coming from all the corners of India. We are involving not only the KSOGA members, we are involving from the surrounding states, Telangana, Andhra, Tamil Nadu, North, Gujarat, everyone. A very beautiful idea. Respected Dr. Jaideep Tank, Dr. Alpesh, Dr. Ajay Mane, Dr. Sampath Kumari Madam, all the senior members of Foxy and my KSOGA colleagues. A very nicely arranged program is this, Wellness of Women. I think theme is very good. And in that, today they are going to cover 3 very important things. One is prenatal care, another is prenatal nutrition, another is prenatal genetic dilemmas. All 3 areas are very, very important. That we want to reduce the maternal mortality of our country. I think if you are able to look into all these areas, and if we understand and if you do sincerely work, definitely we can achieve the target of bringing down the maternal mortality. And all the speakers are excellent speakers and they are selected speakers and they will be doing the job, really a great one. And today galaxy of the Gyans of Foxy have been invited. I think if we go on taking much time, really we'll miss the knowledge. I do not want to take any more time. And more so, this time Foxy Perinatology Committee has been involved. Thank you, madam, for joining. And I would like to thank all the organizers for giving me this opportunity. I wish a grand success for this scientific program.
Thank you, sir. Thank you very much for your words, sir. Your words are always inspiring and encouraging to all of us. Now I call upon Dr. Vidya Topi Madam to introduce our another guest of honor, Dr. Ajay Mane, sir.
Dr. Ajay Mane does not need any introduction.
No, madam, Alpesh sir is senior to me. Alpesh
I
sir
know
is
him
senior
very
to
well.
me.
Presently, no, this
madam.
is very, whatever this is
Vidya
uploaded.
madam.
Yes,
Vidya madam.
bola. Yes.
Alpesh sir is senior to me.
That's what they have put one by one. This is the chronology is wrong. I will take address from
Ajay, we are
Alpesh
brothers, we are
नहीं
colleagues.
सर नहीं फिर भी you are senior so आपका पहले लेना चाहिए सर. I feel that. Please
Sir,
please
Alpesh
Vidya madam.
Gandhi sir, please address us. I don't think Alpesh Gandhi
Yeah,
sir
he doesn't need
has any
introduction.
needs any introduction. And please change the CV of Dr. Ajay Mane because it is an old one.
No problem madam.
Okay.
No problem.
And Ajay, you should please share me the recent one to me. Yes.
Yeah. Alpesh sir please.
Suman Gandhi, madam, please introduce Alpesh Gandhi, sir, madam.
It's okay,
Yeah,
Dr. Shobha.
good
हाँ,
evening.
एक मिनट में
Alpesh sir,
introduce करो.
please address us.
Good evening, one and all. It's nice to see all galaxy of speakers, very well-known personalities, and of course, among them, Dr. Alpesh Gandhi needs no introduction. Very well-known figure of Foxy, and being the president of Foxy 2020, was being the resource person for Foxy GCPR on pregnancy with COVID-19. A resource person to prepare guideline of establishment of obstetric HDU, ICU, that GOI, and also been the resource person to prepare operational guidelines on obstetric HDU, ICU, that is GOI, and resource person to prepare the Foxy's Justosis GCPR on HGP, and also preparing the GOI's guidelines on optimizing the cesarean section rates, and has prepared the National Registry on Pregnancy with COVID-19 Infection. Sir has his book on Principles of Critical Care in Obstetrics, which is available in more than 5,000 world-renowned medical libraries and translated in Chinese as well as Spanish language. RCG has awarded Sir with honorable FRCOG, honorary FRCOG, that received the Best Society, Best RCH Activities, and Best Application Award from Foxy. Has been the convener of one of the most successful annual conference of Foxy AICOG 2017 at Ahmedabad. Then contributed a chapter on sudden obstetrics collapse. PGO's continuous textbook, awarded 51 orations by many gynecology societies across India and internationally. Yes, ma'am. Hospital management course from the prestigious IIHMR Jaipur, sir, has been done, and practicing as high-risk pregnancy expert at Ahmedabad since 30 years. Has been awarded Dr. APJ Abdul Kalam Living Legend Award by DGFS, honored as one of the 7 legends across the world for cervical cancer prevention by IFCPC. And here I present Dr. Alpesh Gandhi. Thank you, sir.
Thank you for the kind words, generous introduction. Namaste, namaskara, namaskaram to all of you. At the beginning, I would like to congratulate KSOGA President Dr. Vidya Thobi, President-elect Dr. Bharti, Secretary Dr. Rajashree, and Dr. Treasurer Dr. Shuman for this very useful, very important initiative, Gyaan Sangam. I really like the name. It's very meaningful and catchy name, and I hope it will definitely attract and it will be useful to all the delegates in future. I am so happy that I am the witness of the beginning of this Gyaan Sangam series. And I would also like to congratulate Dr. Chinmay Ratha, Foxy Perinatology Committee for joining for this program. My very high regards to Dr. Hiremat, my dear friend and the chief patron of KSOGA, and my dear brother, Dr. Ajay Mane. I'm always calling him my brother. So, and for this, my high regards and hello to both of you. And always, of course, high regards to so many eminent faculties across India, Dr. Sampat Kumari, and I can see so many national figures. So my high regards to all of you. Today you have selected a very important topic, and that is a very perinatal care, as nutrition and the genetics. It's very close to my heart. These topics are very close to my heart, and I would say these are the emerging branches. Rather, though we all are aware of it, but I would say this is a newly emerging branches, because I would also like to address this as the preventive obstetric side, and this is very very important in our busy practice. Sometimes we miss some preventive obstetric also. Previously, it was thought that when we can bring more and more pregnant women to the hospital for delivery, we would be able to achieve desirable maternal mortality rate. Of course, it has reduced the maternal mortality rate, but we could not achieve the desirable maternal mortality rate. And then we thought that if we can provide them the good emergency obstetric care, then we would be able to achieve it. But then also we could not achieve the desirable level. And then we thought that quality obstetric healthcare like obstetric HDU are very essential for the backup of these critically ill or high risk patients. With this, maternal mortality rate of our country has reduced significantly, but still there is, if we want to make our country's maternal mortality equal to developed countries, that is below 20 or below 30, then we should understand the importance of this perinatology from the preconceptional period to the postnatal. And it is also very important. Our country's prime minister is very very interesting in first 1,000 days of life, and this is also a significant part of this. So it is very important. We should regularly discuss and we should apply it in our practice. And because of this important significant concept of periconceptional care, counseling and medicine, we can say we can prevent many pregnant women from becoming high risk. So if they become high risk pregnancy or develop critically ill situation, of course obstetric HDO ICU are there, but our aim is to prevent them from becoming critically ill. For that, we should start managing them, taking care them, counseling them from the preconceptional and perinate and the immediately after once they conceive. From there we need to take their care. So I hope this webinar will address such important aspects, and because of this this will help our delegates also in achieving in reducing maternal mortality rate. Not only maternal mortality rate, this will also be helpful in improving the neonatal morbidities and mortality and child health outcome also. So I wish grand success to this webinar, and I also we have so many eminent faculties across the India. I wish grand success to all the to KSOGA and Perinatology Committee for the success of this webinar, and I would like to visit more and more to KSOGA. Thank you very much for your kind
Thank you.
invitation. Thank you.
Sir. And I must congratulate Alpesh
Thank
Gandhi,
you.
sir, for introducing the concept of HDU, high-risk pregnancy and high-risk pregnancy clinics. And we will have one special webinar dedicated to high-risk pregnancy.
Yes,
and we will disseminate his whatever vast knowledge about the HDU and high-risk pregnancy clinics across the country. That is his dream, and that we will make it true.
Dr.
Thank you, sir.
Vidya, I would like to take one more minute
sir.
to inform all the delegates and faculties that we have very good initiative Manyata in the FOXY, that is for the good clinical aspects of labor. Yes, Dr. Jaideep Tank is there. So, hi Jaideep.
Namaste, sir. Namaste, sir. Thank you.
We are
Thank you for
another
joining.
some accreditation program like HRP Care Center.
HRP
So,
Care.
in future, if I get an opportunity, we'll definitely like to address about it.
Yeah, we will do it, sir. Yeah.
Sir, thank you very much.
Welcome, sir.
Thank you very
Dr.
much.
Tank, Dr. Jaideep Tank has come. So could we please introduce him?
Madam, you are supposed to introduce Jaideep sir.
Yeah, that's what I said.
I call upon our President-elect, Dr. Bharti Madam, to introduce our Foxy President, Dr. Jaideep Tank, who has just joined.
Yeah. Good afternoon, sir. And we all know that, of course, Dr. Jaideep Tank is such a ever smiling, charismatic president of the Foxy 2024-25. But just to keep the formalities, we will introduce Dr. Jaideep Tank, who has got a stream of degrees behind him. He's the President Foxy 2024-25. He's the chair of the YGAA committee of the AOFOG. He's the project lead Foxy for the USAID projects from 2020 to 24. Sir has been the Secretary General for the Foxy, and he has been awarded the honorary FRCOG by the Royal College of Obstetricians and Gynecologists, United Kingdom. He's been the past president of the Mumbai Obstetrics and Gynecological Society, and he has been the immediate past deputy secretary of the Asia Oceania Federation of Obstetrics and Gynecology, the immediate past chair of the International Federation of Obstetrics and Gynecology, that is the FIGO Committee for Safe Abortions, past chair of the Publication and Newsletter Committee of AOFOG, past chair Reproductive Endocrinology and Infertility Committee AOFOG, and past chair MTP Committee Foxy. And he has been instrumental in drafting the proposal for FIGO, which resulted in a grant of $13 million for a 10-country project, 8 in Africa and 2 in South America, and was the technical lead for the project. And I'm sure as president, he will try to get some funds for the betterment of women's health in the Asian continent and particularly India. He is instrumental in obtaining the project lead for the largest ever grant awarded to Foxy for over 2 million, that is 16.6 crores from the Melinda Gates Foundation. And I think we need to, that is part of the HPV vaccination is also been funded by this same Melinda Gates Foundation. And he has contributed to the electronic membership management of the voting system of Foxy, which is definitely a game changer. And he has a user-friendly constitution for Foxy and led the development of Foxy statements, cesarean rates, hysterectomy rates, contraception, ART, surrogacy bill, and the Foxy WPs and International Supreme Court ruling on PCP and DT. So without wasting much time, I know Dr. Jaideep Tank has to hop in and hop out of many, many meetings. We request you to kindly bless us, and we thank you for gracing this occasion in spite of your busy schedule, sir. Welcome to Gyaan Sangam KSOGA.
Thank you. Thank you very much, Bharti. I'm very sorry I got delayed.
No, sir.
Previous meeting ran over a little bit despite
we understand, sir. We understand. You can join us anytime.
Thank you. It's always a pleasure and privilege to be a part of anything which KSOGA organizes. And I'm so very happy to see Dr. M.G. Hiremat, sir, the chief patron of KSOGA. And I often say that KSOGA owes him a very large debt of gratitude for his dynamism, his abilities, and his leadership to make KSOGA what it is today. As is true of course, the patron of KSOGA, Dr. Nagaraj, the president, my good friend, Dr. Vidya Thobi, the honorary secretary, Dr. Rajeshri, and the treasurer, Dr. Suman. Congratulations, Bharti. You are the program convener. You are the president-elect of KSOGA, and you are also a speaker in this session. Thank you for putting this together and getting such eminent faculties to be a part. I'm delighted to share a podium with Ajay, my dear friend and brother, also the vice president of Foxy. And of course, Alpesh Bhai, who had the, I won't say great distinction of leading Foxy through COVID. And I think Alpesh Bhai, you will always be remembered in history as someone who took a threat and converted it into an opportunity. Always a pleasure to hear from you. And of course, chairpersons, Dr. Aruna Suman, Dr. Jagruti Shah, and Dr. Vidya Thobi is, of course, the second speaker. And this will be followed by a very important panel on prenatal genetic dilemmas, moderated by Chinmay, who had just conducted a wonderful conference at Pondicherry and does such wonderful work as Perinatology Committee Chair. Thank you, Chinmay, for everything. And of course, Dr. Sampath Kumari. Everybody knows Dr. Sampath Kumari. She's always smiling, always efficient. And although here it's written Vice President, South Zone Foxy, she also had a leading role to play in the formation and the continuation of the TNFOG, which, as I said last week, is a byproduct of COVID, and she manages it so well. And of course, chairpersons Dr. Mahesh, Dr. Krishna, and panelists Dr. Tirupati, Dr. Shehnaz, Dr. Nigat, Dr. Mahesh, and Dr. Sri Lakshmi. I'm delighted that you have faculty from all parts of the country, from Srinagar to Nellore to Singauli and all over the country. Thank you again, KSOGA, for putting this together. Thank you for having me here. And again, I do apologize. I ran late because I had another meeting, and I'm very happy to inform that Foxy might be receiving some more money
Great.
very
Yes,
shortly. I
great.
can't confirm it officially, but I think we should be getting another 6 crores to work on top of the 16 crores that we've already got. We'll probably get another 6 crores maybe in a month or so for more work on women's health.
Great, sir.
Thank you very much,
Excellent.
everybody, for your support.
Thank
It's a
you.
real
Thank you for
pleasure and privilege.
joining, Dr.
Thank you.
Jaydeep.
Thank you for joining.
Sir,
Jaydeep.
thank you for coming.
Best
Thank
luck,
you, sir.
Jaideep sir.
Thank
Best
you.
luck. Jaideep sir, best luck for your mission of
Right.
6 crores again.
Thank you.
Thank you, sir.
Jaideep has blessings from Ram Lalla Ayodhya. He had visited.
Thank you.
He's
That was
one of the very
amazing.
fortunate who could visit.
Yes, correct.
Thank you so much, Jaideep sir. Thanks, sir, for coming and blessing this program. Now I call upon Dr. Vidya Tobi Madam, our dynamic president, to introduce Dr. Ajay Mane, another guest of honor.
Okay, no need.
No,
Hello.
it is always pleasure to introduce Dr. Ajay Mane to KSOGA family, as well as the people who have joined. They all know about you, but I just introduce you. The CV here is a very old one. Now, at present, he is a vice president Foxy, and he's a member of National Inspection and Monitoring Committee, PCPNDT, Government of India. Medical legal consultant since 19 years, and he gives any advice free of cost. And he is a chairperson AMOG's website, and at present, I think he is joint secretary.
State coordinator now.
State coordinator for
That's
AMOG's.
totally
Yes. I met him recently in AMOG's conference, and his leadership oozes. He always gives tips and tricks how to manage an organization. He is himself an organization.
Hello.
So, welcome, Dr. Ajay Mane to KSOGA, and please address our gathering today. Yes.
Thank you, Vidya madam. At the outset, I must convey my gratitude to KSOGA for inviting for the Gyaan Sangam, which is a very nice series for all practitioners as well as the students and the residents. So, respected Jaideep sir, my elder brother, the respected Alpesh sir, then again my elder brother, respected Hiremat sir from KSOGA, who is the chief patron. Though Nagaraj sir is not absent, we must endorse his name, Dr. Nagaraj sir, then our sister, Dr. Vidya ma'am, Dr. Rajeshri Paladi ma'am, and Dr. Suman Kadi ma'am. Then President-elect Dr. Bharti ma'am, who is a star of today's show. Then the chairpersons, Dr. Aruna Sumanji and Dr. Jagruti Shah ma'am. I like the topic, prenatal, everything prenatal care, prenatal nutrition, and prenatal genetic dilemmas. Because the discussion today we are having, it will help in each and every corner of the prenatal discussions. Nutrition, we were talking in Ayurveda since 5,000 years, but the modern medicine was not considering it as an important topic. But now we are coming to know that the base behind every disease and the base behind every treatment is the nutrition. And now we are having the topics important to the nutrition. And the best person to speak on the nutrition is Vidya Thobi ma'am. She has got PhD unofficially in the nutrition. So Vidya ma'am is the perfect person for that. And the prenatal care will be by Bharti ma'am. And the prenatal genetic dilemma, none other than the greatest person, Dr. Chinmay Rath, and will be expert, our senior friend from Foxy, Sampath Kumari ma'am. So it will be a nice discussion basically. And the chairpersons, Mahesh sir and Krishna sir, and the panelist, Shai sir, then Shehnaz ma'am, then Nikhat ma'am, Mahesh sir, and Sri Lakshmi ma'am. So it will be a great feast for all those who are attending this. So I convey my gratitude for calling me, and best luck for this Gyaan Sangam series all the way, because these webinars are blessed in disguise, and we are very much thankful to Alpesh Gandhi sir for giving us this idea of having webinars in the era of COVID. So Nirmata Sukhi Bhava is idea ka. So HDU as well as webinars, both are idea given by Alpesh sir. So he's the innovator. So thank you, sir. Thank you very much. And thank you, KSOGA, for calling me. Thank you, everybody. Best luck.
Thank you, sir. Thank you, Dr. Ajay Mani sir, for gracing the occasion, sparing your valuable time for us.
Thank you, Ajay Mane sir, for your wishes and blessings. Now we have got wishes and blessings from all the seniors of Foxy and KSOGA. Now it's the time to start our first session. For this session, I call upon Dr. Aruna Suman Madam and Dr. Jagruti Shah Madam as chairpersons. Arun, please share the CV of Aruna Suman Madam. It's an honor to introduce Dr. Aruna Suman Madam. Madam is Professor OBG, HOD, Government Medical College, Telangana, Jagtial, Telangana. She is Joint Secretary of Foxy 2021. She was Organizing Secretary of very successful ASCOG, which was conducted in Hyderabad last month. Practical Obstetric Committee Foxy member 24-25. South Zonal Coordinator Foxy 2022-23. Adolescent Health Committee Foxy member 2016 to 2018. She is a Vice President of OGSH 20-23, TCOG Treasurer since for 2022-23. She is Trainer of Trainers in National Health Mission. Dakshata Comprehensive Abortion Care PPIUCD Rashtriya Kishori Swasthya Karyakram. Laksha Assessor Telangana National Quality Assurance Standards NQAS Assessor TOT Telangana. She has given a talk in prestigious GC Saraya CME 2023, OGSH Oration in TCOG 2022. She has published many articles in national and international journals. She has won many awards, Dira Award, IFS Award of Excellency, prizes for 4 papers at national and international conferences, worked in organizing committee for many national and international conferences. Madam, we welcome you to chair this sessions for session 1, madam. Next, I call upon Dr. Jagruti Shah, madam, to chair the session. She is president of Sagar OBGY Society and associate professor in Bundelkhand Medical College, Sagar. We welcome you, madam, to today's program.
Thank you, Dr. Shobha, for that kind introduction. And I thank the organizers, Dr. Bharati Rashekar Madam and Dr. Vidya Tobe Madam. Dr. Vidya Tobe Madam being the president of KSOGA and president-elect Dr. Bharati Rashekar. Thank you for the opportunity for this Gyaan Sangam, where there's a real Sangam of East, West, North, South zones of India. Thank you so much. Can I have the CV of Dr. Bharati ma'am?
Yes, madam. Arun, please share.
Oh, it's okay, Dr.
No. Please let me introduce my dear friend. Yes, Dr. Bharati Rashekar, and she is very dynamic and a good academician. Thank you for thinking about this Sangam. Really, it's great idea that you have got. She is IMA State past Vice President, IMA Women's Wing EC member. She is HSOG, HASOG past President, Hassan OBG Society past Secretary, Hassan PC PNDT Committee member. She is Foxy Public Awareness Committee, South Zone Coordinator, member Preventive Oncology Committee, member Food Committee, Foxy Food Medical Equipment and Drug Committee member, trainer Foxy Dhira program, trainer Foxy RAC program. And she has got many awards and activities and past President Medal from Topper in Final MBBS Madras University, Foxy President Rotating.
I think Aruna, you can stop.
Trophy as Secretary HASOG, and Dr. T.K. Tank Award twice as HASOG Secretary and President, and faculty in various state and national conferences, actively involved in adolescent health awareness activities, conducts first aid and basic life support workshops for public drivers and colleges, President Rotating Trophy as President HASOG, and recipient of Rajotsava Award for work in healthcare in Hassan, cancer cervix screening camps, screening around 5,000 women, HPV screening camps and HPV vaccination free of cost for the immunocompromised, awareness camps on cancer prevention in women. Her special interest is non-communicable diseases and special interest are adolescent health and high risk. I welcome Dr. Bharti Rajshekar to present her first talk.
Thank you, Dr. Aruna. And at the outset, I would like to thank my president of KSOGA, Dr. Vidya Thopi, and Chief Patron MG Hiremat for giving me this opportunity to be the program coordinator of the Gyaan Sangam, so that we are pleased to have faculty from Kashmir to Chennai and Andhra Pradesh, Telangana, Maharashtra, and Madhya Pradesh and UP. So without wasting much time, I will share my screen to start the first topic, that is preconceptional care. So I think yes, it is visible, Rachna?
Yes, it is visible.
It's visible, ma'am. It's clear.
Thank you.
Please put it in the slideshow.
Yeah, it's there. Yeah. So preconceptional care is what we need to do for a healthy Gen Next. So Gyaan Sangam is, of course, an interaction of all the knowledge so that we exchange, collaborate, contribute, communicate, and do much for our women. So what are the facts? Almost 4 out of 10 women report that their pregnancies are unplanned. Perinatal deaths are 50% higher among babies born to adolescent mothers, and up to 10% of pregnancies of women with untreated gonococcal and infections results in perinatal death. That is all because of poor prenatal care. And maternal undernutrition is something which is also contributing to anemia, iron deficiency anemia, and at least 20% of maternal mortality cases, and female genital mutilation in those countries where it is quite prevalent. And in the absence of interventions, rates of HIV transmission from mother to child are again between 15 to 45%. So what is preconception care? Preconception care refers to health of people during their reproductive years or the years they can have a child. It focuses on taking steps of how to protect the health of a baby they might have sometime in the future. So what is the aim of preconception care? Well, preconception care is the provision of biomedical, behavioral, and social health interventions to women and couples before conception occurs. And what is its aim? It aims at improving the health status and reducing behaviors and individual and environmental factors that could contribute to poor maternal and child health outcomes. Its ultimate aim is to improve maternal and child health outcomes in both the short term and the long term. So preconception programs are required to promote good health during pregnancy, prevent health problems, and respond to those problems that occur. But however, the reality is that many women in low and middle income groups do not have adequate access to the prenatal care because most often they come to us only after they conceive. So why preconception care? Evidence has shown that there is a growing evidence that extending the maternal, newborn, and child health continuum with one step before prenatal care. We are all becoming alert about the antenatal care and the postnatal care and the contraception, but we have to move the pendulum towards prenatal care, that is before pregnancy can increase. This can increase the well-being of women and couples and improve the subsequent pregnancy and, very importantly, the child health outcome, that is the generation next, will be more healthy. So this will definitely reduce child mortality, maternal mortality, birth defects, low birth weight, preterm birth, neonatal hypoglycemia, mental retardation and cretinism, hypothyroidism in children, cancers, diabetes and cardiovascular disease in mother and child, congenital and neonatal infections, and prevent vertical transmission of HIV and STIs. And in these women who do not have prenatal care, preconceptional care, there is an increased incidence of reduced breastfeeding, underweight, and babies with neonatal and perinatal infections. So there's a lot of evidence which has shown that when we provide preconceptional care, here too referred as PCC, will definitely bring about a change in the maternal and the child outcome. It's not only the fetal outcome, even the children who are going to be born of those mothers who have PCC is going to be much better. So we have to do a lot of capacity building to address these issues. We have to start early. Too early, unwanted and rapid successive pregnancies we are seeing in our adolescents. So we need to keep these girls in school, prevent child marriages, educate girls and boys about sexuality, build a community to support and prevent early pregnancies and provide contraception to adolescents, and enable our adolescents to receive contraceptive services and sexual abuse. So this is how we can do the preventive strategies. And the WHO has come up with a very good package which says that for an effective preconceptional care, we have to address all these issues. There is the nutritional conditions, genetic conditions, environmental health, try to prevent vaccine preventable diseases, prevent female genital mutilation, prevent early pregnancies and repeated pregnancies, prevent STIs, HIV, and see that they have a good mental health. There is no psychoactive substance abuse and tobacco abuse in the childbearing age. So evidence has shown that PCC has a definite positive effect in the general population, as well as especially those women who become pregnant when they are having diabetes mellitus. So these are the evidences which have been there, and I'm not going to go through these. And trends in the indices in USA have shown that with increased preconceptional care, there has been a decrease in the mortality rates. However, because the uptake of preconceptional care is not as expected, we still continue to see children suffering from low birth weight and preterm deliveries. That is because very few women come to us for preconceptional care. So when they do not come to us for preconceptional care, the infants are not dying because of the pregnancy-induced problems, but rather they are dying of other problems like congenital anomalies and very low birth weight or preterm deliveries or infections and congenital anomalies. So, however, that is why early prenatal care is too late. Whatever we are doing now is it has one of the reasons for the decrease in the improving pregnancy outcomes is because the women come to us late and we have failed to intervene before pregnancy to detect, manage, and modify these risk factors. So we are rather too late because most of them do come to us after they have conceived. So by the time the woman makes her first prenatal visit, most fetal organs are already formed, and many interventions to prevent birth defects or adverse maternal and infant outcomes may not have any effect. So this is where the national organizations, we need to have a routine preconception care, because right now the utilization is as low as only 13.4%. And I think Chinmayi will be telling us one of the talking towards prenatal genetic anomalies which could be prevented. So we need to intervene very early. That is, the preconception is we have to start at school age and adolescence, not that just the reproductive years, but we have to start quite early in this preconception care. That is the essence. And pregnancy always takes two. So whenever we talk of preconceptional care, we are always talking about the girls. But however, we have to reach out to all segments of the population, including couples planning a pregnancy and couples not planning a pregnancy, but they are in the reproductive age group. Special attention to adolescents, both males and females. And we must consider starting early. And the other groups are those with diabetes, immigrants, people living with STIs and HIV, genital mutilations or genetic conditions or previous bad obstetric histories, or underweight and overweight women also need to fall into this category. So we need to focus on all of them. And preconception care will be divided into 4 categories by the ACOG and the AAP. They say that do a maternal assessment, give the necessary prevent vaccine preventable diseases by appropriate vaccination preconceptionally, screen them for all the HIVs and STDs and genetic disorders preconceptionally, and counsel on administration of folic acid, stopping smoking and alcohol cessation, weight management, and lifestyle modification. So what is that we can do now? There is a huge checklist when we take the history as to what are we supposed to screen for women and men in preconceptional care, which I will summarize in the end. I've just put the guidelines there, so I'm not going to read this very busy slide. So first of all, we need to educate these eligible boys and girls about smoking, alcohol abuse, and drug abuse has to be given up when they are either going to have a baby or planning in the near future, and a folic acid supplementation of 400 micrograms daily as a standard of care has to be followed in these eligible people. And we need to counsel them about sexually transmitted infections, including HIV, and treat them. Talk to them about contraception and pregnancy spacing. Give them a healthy body diet and ask them to achieve good weight parameters. Talk to them about importance of oral health, and of course, talk to them about the increased risk of hepatitis C with the habits of tattoos and body piercings, and try to avoid environmental toxins such as lead and other occupational exposures like radiation. Lead is there present in most of the few nail colors or other paint industries, which we need to tell them to be careful about, and also screen them for genetic disorders by taking a very pertinent history when we talk to these people. And we do the physical assessment, includes a detailed physical examination, do a carrier screening, check their immunization records to see whether they have got rubella, hepatitis B, and varicella vaccinated, or give them to them preconceptionally before they conceive, and also take the history of any past obstetric problems that they've had, and identify women or men who are having domestic violence, and do a psychosocial screening for parent readiness. So once we have done that, we have to screen them for anemia, supplement iron and folic acid, and give them all the necessary information, screen for diabetes, screen for thyroid disease, promote exercise, and promote salt iodization. About nutrition, our President Dr. Vidya Thobi will be talking about it in detail in the next session. And these are the same preconception interventions that I've already spoken to you about. So we have to move forward. How do we move forward? See, moving forward, we have to have strong delivery channels, and there should be an emphasis in the community levels. So we need to go to the communities, we need to go to the social media, and we have to bring out these packages either by the associations or by individual communities, so that we have a proper success in this preconception care. So we have to have a proper package of this and take to them. In the good entry point would be for young children at the age of 10 to 14 years. We could talk to them about alcohol and smoking, the hazards of that. We could talk to them about nutrition, talk to them about exercise and STIs, and try to inculcate a sense of responsibility as young as possible. So we need to have a lot of tools which we have to right now put across, and there is a need for capacity building, including our healthcare workers, and there is a need for a lot of research in this field, which is the message to the doyens of Foxy and KSOGA sitting here. However, not being put away by this huge action plan that I have put across, let us like to hang on to the low hanging fruit. We have many interventions which are in our reach of the hand. So what is that? Treatment with folic acid deficiency, very well we can do it. We can prevent and manage anemia before they become pregnant. Weight control can be achieved. Diabetes prevention and management can be controlled. Prevention of unsafe abortions and sex selection can be detained. We can ask them to delay their pregnancies by advocating contraception and safe sex, and also tell them to keep away from substance abuse so that they have a very healthy child. So it will always fall into these categories. There is early detection, management of high risk before conception, and create an awareness. So these are the elements which are going to be taken into the maternal history, environmental hazards, nutritional needs, genetic history, and the maternal age factor. So I'm not going to go into this. Of course, lifestyle, you recommend regular moderate exercise, ask them to have their nutritional deficiencies should be addressed. If they are milk intolerant, you give them calcium in other supplementation. You do not avoid overuse of vitamin E and vitamin D, because the limit is only 400 IU per day for vitamin D, and vitamin A is 3000 IU per day. It can be deleterious if we hypervitaminosis in the preconceptional and the first trimesters. Try to reduce the intake of caffeine and screen for social issues, as well as counsel them not to take over-the-counter medications or nutrition supplements without the physician's advice, because very often we have that they have taken some antibiotic or an anti-epileptic and they realize that they are pregnant and they come to us and they are worried about the teratogenicity of these drugs, and we also fall into a dilemma. We need to assess the previous complications from previous pregnancies. We need to take a detailed genetic family history and also trace out from which ethnic background they come from, because certain disorders like thalassemia are prevalent in the certain ethnic communities. And when a mother is below 17, of course, it comes under the POXO Act. But if the mother is a very young mother or a mother above 35 years, we need to advise them and tell them that the appropriate age would ideally be between these two ages. And nutritional need, I'm not going to address this point now. And avoid environmental exposure to environmental toxins. But then, why have we left the men out? Most often, we are definitely leaving the men out. So, no. Preconception care is also there for men. We need to advise them to stop smoking, use mobile phones only when needed, avoid increased temperature around genitals because it can cause sperm abnormalities, inculcate a relaxing schedule, stop consuming alcohol, steroids, maintain a healthy weight, plan for finances, and think about parenting. Because very often in your clinics, you may see that the husband thinks that the whole responsibility of having a baby entirely falls on the mother. Because even when we advise them to get the basic tests such as blood group or a thyroid or a blood sugar, they say, why should I get it done? So this has to be, an awareness has to be created, and a special focus on women with suffering from any of these disorders and adolescents. So the delivery channels could be primary care in the primary health setup, community-based organizations, existing Ministry of Health programs should start incorporating preconceptional care. Now that we have achieved a reasonably less decrease in the maternal mortality and infant mortality, it is time we shift towards preconception care so that we can achieve much better indices in the days to come. And the educational system should incorporate these, as well as the social welfare and the workplace programs. So these are going to be the marketing strategies have to come through the government, through the public, as well as the media, they have to come. And one thing I thought about is the PCC promotions can be done very effectively through social media, because all of us know that the generation now is very much hooked on to the social media, and anything that comes through SMS, Facebook, YouTube is readily grasped by them rather than the television and the news media. But definitely the social media is a very good channel to hook on to the preconceptional care. And of course, WHO has supported many countries to bring about these regional platforms and introduce professionals and provides a methodology to understand these, and various strategies of preconceptional care have been incorporated into a package and very well put across on the WHO website, which we can all take up and develop a roadmap so that we can see that our women and our children are going to be healthy for years to come. And evidence has shown that these strategies have brought about a huge improvement in the high income groups as well as in the low income groups such as Philippines, Sri Lanka, and Bangladesh. So this is the strategy what I would ask the policymakers to take up so that we optimize women's health, minimize risks to her and the fetus, and improve pregnancy outcome, provide information necessary to make informed decisions about future reproduction. So it is the responsibility of the community, the family members, the health professionals, the policy makers, faith-based organizations, as well as political leaders, along with our associations like the FOXI, the IMA, and IAP. We need to talk about preconceptional care. And this is a wonderful handbook brought about by the WHO, which is available on their website, where they have laid down the roadmap for preconception care interventions, which you can download. And so that is how we can take about preconception care to a new level and reduce the infant mortality and morbidity. I'm sorry, these were the slides I was supposed to pick. So now we have to start shifting from healthy mothers to healthy babies was all that we were talking about today, all these years. I think we have to start talking about healthy women, and I would add healthy men, so that we have healthy mothers and we have healthy babies. So preconceptional care is very essential to improve the maternal health and pregnancy outcomes, as well as it helps to detect any pregnancy abnormality which affect the mother and baby. I thank you all for the patient hearing, and a humble request to support me for my FOXI chairperson elections, where I will be going for the FOXI Perinatology Committee. I thank KSOGA and all the FOXians and all the delegates for giving me this opportunity to be with you today. Thank you.
Shobha. Is Shobha there? Okay, I request Shobha, unmute. Is
I
Dr. Jagruti Shah ma'am there?
Aruna madam and Jagrati Shah madam to give your comments on the talk. Aruna madam, are you there?
Yes, I'm there.
Yes, yes.
Okay. Actually, congratulations, Dr. Bharati. It was an excellent talk. You have covered the holistic approach for preconceptional care. You have covered everything. So it's important to start preconceptional care at adolescent age group. That's really good, covering all the couples, married and unmarried. Especially, we have to cover even the men, which is important. And you also told regarding the domestic violence, this which is very important nowadays, to optimize the health of the women before conception. Thank you so much, and that's a really good, you have given us a good knowledge about preconceptional care.
Thank you, Dr. Aruna.
Thank you, madam. Jagrati Shah
Is
madam,
Dr. Jagrati Shah ma'am is there?
would you like to say a few words? Bharti madam, that was a wonderful talk, and I think we should thank our KSOGA leaders to taking the spotlight from not only antenatal area but to prenatal area, which is most important because prevention is always better than cure. And your talk was very much enlightening, madam.
Thank you, Dr. Shobha. Thank you.
Now I call upon the chairpersons to introduce our next speaker, Dr. Vidya Tobi madam, our president. Aruna madam. Arun, please share the CV of Vidya madam. Aruna madam.
Okay, I'm there. I feel really wonderful, and it's my privilege to introduce none other than Dr. Vidya Thobi ma'am, who is a very good friend, down to earth and always active, President of KSOGA 2023, Chairperson Food, Drugs, Medico-Surgical Equipment Committee, FOXY, 2018 to 20, Best Committee FOXY Award for Mehru Dara Hansotia 2020, ICOG Governing Council Members 2023 and 25, FOXY Champion Award 2019, National Corresponding Editor for Jogi, Organizing Chairperson KSOGA 2023, President Bijapur OBG Society 2009, Secretary Bijapur OBG Society 2007, publications in various books and contributions to FOXY, FOXY Focus, and speaker at national and international conferences, papers at national and international conferences, organized various CME workshops and awareness programs, advisory faculty of boards, Rajiv Gandhi University of Health Sciences, postgraduate and undergraduate teachers for 30 years. I welcome you, Dr. Vidya Tobi ma'am, to please give your talk.
Thank you, Dr. Aruna, those kind words. And I really missed you meeting in AICOG, really.
Yes, ma'am.
Yes, you are such a dynamic secretary, I know, and you have done many programs. And I wish you for your future endeavors also.
Thank you so much, ma'am. Yes, I need blessings.
Yeah. As a KSOGA family, I welcome all KSOGA members as well as the faculties and delegates who have joined. Please, Arun, can I share my screen?
Yes, madam.
I'll just try to share my screen.
Yes, madam, it's visible.
Yeah, I'll make it
full screen, ma'am.
Full screen. So, yes, today we will be touching upon the preconceptional nutrition. Bharti has covered almost all the other aspects of preconceptional care. So I cannot emphasize the importance of good nutrition. So it covers all the life across any woman, I must say. So pregnancy and lactation gives additional demand of this nutritional part. And also we cannot neglect the adolescent nutrition. So adolescent reproductive age And of course, we have to maintain adequate health for our musculoskeletal health in menopause. So we have to establish a good nutrient reservoir, not only preconceptionally, but also for the menopause. So menopause is also important transition, I must say. So pregnancy is an exceptional phase in a woman's life that her health, well-being, and diet influences the health, not just one, but two individuals. There is now a growing recognition of importance of adolescent health and women's preconceptional nutritional status to improve the maternal and infant's outcome. WHO report shows that the preconception care has a positive impact on maternal and child health. So, maternal nutrition, when we have to interfere, that is a big question. And the life course, we always talk of infancy, then childhood and adolescence. These perspectives have to be touched. We have to extend this continuum with one step before pregnancy, which can improve the pregnancy and childcare. We always talk of effect of various. May I request to make every.
Please mute, every one of you, please mute.
So it is disturbing.
Dr. Krishna Vardhan, please can you mute?
I don't know why I'm not able to listen to him. Okay. So preconception and in utero environment is very detrimental, and it leads to the developmental plasticity and also affects the phenotype. We always talk of epigenetics. So maternal diet and body composition, like simple carbohydrates or various energy substrates, micronutrients, folates, B12, these are the micronutrients. So macronutrients and micronutrient balance and the metabolic status definitely is going to affect the potential oocytes and the embryo responses. And there occurs the epigenetic modifications, gene expression changes, altered intracellular signaling, as well as there is a metabolic stress, apoptosis, altered cell differentiation and proliferation. Leads to potential fetal consequences. It alters the fetal growth rate, alters the setting of the neuroendocrine axis, and of course, abnormal birth weight, which again has got potential long-term consequences like stunting, impairment, neurodevelopmental changes, obesity, and even we talk of non-communicable diseases like cardiovascular and metabolic disorders. So there is an intergenerational circle goes on, and definitely it affects. So we talk of nutrition and epigenetics, and these in utero environmental condition, these epigenetic changes, what we talk of in fetus, there occurs the permanent alteration in the metabolic system and increased susceptibility to the chronic disease. So suboptimal maternal nutrition causes changes in the gene expression. That is what ultimately occurs. And it is called as nutritional epigenetic change. So why this preconception care? Already Bharti has covered everything. But what I want to stress upon is preconception nutrition interventions which are targeted to the woman of childbearing age in the period before at least 2 years and in between two consecutive pregnancy also. We cannot say that just before first pregnancy, but every pregnancy we have to consider various nutritional interventions. So why it is important? It is a special opportunity to intervention, and the critical developmental processes like embryogenesis, which always we talk on, it is always affected by the mother's nutritional status and nutritional stores. So availability of the adequate amount of nutrients just before conception and during early pregnancy may influence the critical processes of fetal development. Maternal underweight during preconception period, it was associated with preterm birth and small for gestational babies. And overweight and obesity during this period also increases the risk of preeclampsia, gestational diabetes, and cesarean sections. So preconception care addressing nutrition should include one is dietary adequacy, healthy weight, and any medical nutrition therapy. So, what do you mean by dietary adequacy? The woman in the preconception period should be advised to eat nutrient-rich food. The factors that affect the food intake includes the availability of the food, income, that is the socio-economic status of a woman's herself belief, choices, social circumstances, traditions, cultures, education, and geographical aspects. The dietary supplements, although many of the requisite vitamins, minerals, essential fatty acids, or other constituents are found in the food, the physiological demands of the woman during preconception and pregnancy may require additional dietary supplementation. And as I was talking about the family, the cooking process, and all those things also do matter. Requirement of folic acid, calcium, iron, zinc, vitamin D, vitamin C, and vitamin B increase substantially during pregnancy, and that should be supplied adequately during in preconceptional period. So, what are the nutritional risks during preconceptional? So, nutritional risk factors: one is teenage pregnancy. The age is also an important factor, and 50% increased risk of stillbirths and preterm births occur if the girl is married in the teenage. Even the advanced maternal age, there is perinatal death is increased by 44%, preterm birth by 29%. There is an increased risk of Down syndrome. Various micronutrient deficiencies. We know iron deficiency anemia is very common, which is associated with the increased risk of fetal growth restriction, low birth weight, and small for gestational age. Folate and multivitamin deficiency, we all know that what it causes is a neural tube defects, and how the underweight and overweight woman will have different difficulties in the weight of the baby as well as the operative deliveries. So these are the in a nutshell, these are the nutritional interventions during preconceptional period. One is supplementation of folic acid, one adequate information, education, and nutritional counseling where we lack that should be given to all the women. Monitoring the nutritional status, taking balanced diet. What do you mean by balanced diet? No, none of the obstetricians they know. So it should be a micronutrient dense food. Screening and management of diabetes mellitus. If already the patient is having GDM in her previous pregnancy, she has to be managed properly. Treatment of existing medical conditions, promoting exercise, consumption of iodized salt. These are the interventions. These FIGO recommendations in preconceptional care. Various professionals can be involved, like community health workers, nutritionists, family doctors, even OBGYNs, midwives. And what assessment they should do is they should always take a history of diet composition, physical activity, height, weight, and BMI. What is the obesity risk? Waist circumference, other anthropometry should be checked, anemia, and risk of specific nutritional problems, and the various deficiencies of folic acid, folate, how much she is consuming, really she is having these nutritional deficiency, we have to check. Then you have to discuss with this woman if she comes for preconceptional counseling. You have to discuss about the importance of healthy diet and exercise, problems of sedentary behavior and such as screen time, weight loss counseling if she is obese, risky behaviors like alcohol and smoking and exposure to the substances like tobacco, alcohol, recreational drugs, environmental toxins. Of course, some of the environmental toxins we cannot avoid, chronic disease screening and management, some of the supplementation, folic acid supplementation, and other whatever micronutrient supplementation as per required. So these professionals should be properly trained to take an history and do the required nutritional interventions. So these are the FIGO recommendations for the preconceptional dietary daily intake requirement. I'll not go into the details. This is on the website. You can just download. So it even the proteins, fatty acids, carbohydrates, folates, various vitamins, these all are given there. So you have to define what is healthy diet, and that should have this pyramid. We all know what is a pyramid, what is an unhealthy diet, what and how the lack of physical activity is leading to the various global risks to the health. So you have to have a one plate which has 4 parts, and how much carbohydrates, how much proteins, how much she has to take fat. All these you have to explain to woman who comes to you for the preconceptional care. What is this? That is BMI, whether it is a screening tool for the nutritional status. One should know how to calculate the body mass index, that is weight in kg divided by height in meter square. So you have to define the classification, whether she is severely thin, moderately thin, mild thin, underweight, healthy weight, overweight, grade 1 obesity, grade 2 and grade 3. So any woman, we say that she has to enter the pregnancy with a BMI of less than 25. That is 25 is the ideal, of course. So malnutrition, if in India, malnutrition is also very common, and it refers to the deficiencies, excesses or imbalances in a person's intake of energy or any other nutrients. The term malnutrition addresses to three broad groups. That is, one is undernutrition, micronutrient related, that is silent malnutrition. So lack of important vitamins and minerals. And overweight is also malnutrition, that is obesity, diet-related non-communicable diseases like heart disease, stroke, diabetes, and some cancers. So overweight leads to these complications. So what is our sustainable that aims to end all forms of hunger and malnutrition by 2030? So we have to aim to this, tackling that. We have to address to adolescent nutrition as well as preconceptional nutrition. So I just want to comment on this is when mother takes only short intervals between the pregnancy and they have many children, this also can exacerbate the nutrition deficiency. So there is no time left for the preconceptional building up of her nutritional deficiency. So healthy eating in adolescent is also very important. And so this is, we have to address the adolescent nutrition and the risk factor for the poor nutrition. We all know that the adolescent, they don't have, Sampath is here only in our audience. She has addressed many times the adolescent nutrition and the whatever the consequences that occur with the adolescent nutritions. So the adolescent tend to take calorie intake from various bad pizzas, burgers, and dessert, and they go into the malnutritions. We talk of micronutrients in preconceptional period and pregnancy. Are they essential? Yes. What is micronutrient? It is the term which is used for the vitamins, minerals, and other chemicals which are in very small quantities, but they play essential role at the cellular and molecular level. Aspect of preconception care is these deficiencies can be rectified by the micronutrient supplements during pregnancy, but they are not enough to improve the long-term pregnancy and fetal outcomes. So we have to give them preconceptionally. So adequate nutrition is very, very vital. And we have to replenish her reserves so as to able to nourish the fetus as well. A well-nourished fetus enters the life with a good health. So we have explained the epigenetics and the consequences. So example of efficacious, the single micronutrient intervention include folic acid. We all know that it prevents the neural tube defects. Iodine to prevent cretinism, zinc to reduce the preterm birth, iron to reduce the risk of low birth weight, and calcium to prevent preeclampsia. So these are the very important micronutrients. And what are the effects? We all know the effects of micronutrient deficiency lead to anemia, hypertensive disorders in pregnancy, preterm birth, placental abruption, stillbirth, neural tube defect, poor neonatal immunity, all the complications. We all know that if you don't have a proper nutrition or micronutrient supplementation, these complications are bound to happen. And this is just a conceptual, you can just see the framework, how the micronutrient deficiency lead to the chronic diseases in the offspring. So we have to supplement this micronutrient compulsorily in the preconceptional period. So one by one we can discuss the folic acid. We know it is a type of water soluble vitamin which is required. Most important, you should underline, is a DNA synthesis and cell division. And it is fortified in cereals. We can supply them in the flour also. wheat flour and all to prevent the development of neural tube defects. WHO recommendation, any woman who is trying to conceive should take the folic acid supplement from the time they plan pregnancy till 12 weeks of gestation. Even a Cochrane review concludes that the folic acid supplementation taken in the periconceptional period reduce the risk of development of neural tube defect by 72% and the risk of recurrence of neural tube defect by 68% compared to no intervention. So there are various studies published. Even ACUG recommends the supplementation of 400 microgram of folic acid per day for the average risk woman and woman who is at risk of a neural tube defect, like the previous pregnancy with neural tube defect or obese woman, diabetic woman with poor glycemic control, or patient is having some epilepsy, they should be counseled to take 4 milligram of folic acid per day. These are the various folate rich foods which are available, and you should encourage these women who comes to eat them in plenty. So iron deficiency anemia is very, very common, and this is because of poor diet, menstrual blood loss, and multiple frequent childbirths. We all know the etiology of iron deficiency anemia. And we know that the fetal complications, prematurity, and fetal growth restrictions are common when there is iron deficiency anemia. So these women should consume not only iron-rich foods, and we have to supplement with the iron tablets also to them. So we always talk of jaggery and iron-fortified cereals here, and these are the iron-rich foods. Again, you have to advise these women to consume. For all adolescent girls in areas where the anemia prevalence is more than 20%. And ACOG also recommends that in the preconceptional visit, the screening should be done of these women for the risk factor of iron deficiency, and you have to identify and treat this anemia. Vitamin D, we all know, phosphate equilibrium, and also the bone metabolism. Vitamin D deficiency during pregnancy is to be associated with preeclampsia, low birth weight, and even the impaired glucose tolerance in pregnancy. So vitamin D is involved in various metabolisms, and even the bone development and impaired growth of a fetus as well. The ideal dose of vitamin D during periconceptional period is really unknown. The vitamin D deficient woman should be given information on vitamin D sources in the diet and supplementation. RCOG recommends the daily dose of that is 400 international units for all during preconceptional period and pregnancy. And at the high risk of vitamin D deficiency with increasing skin pigmentation or reduced exposure to the sunlight or obese women, they are advised to take at least 1,000 units per day. These are the vitamin D rich foods and fortified foods. Fortified milk also we get, and we ask these women to consume this. The calcium plays an essential role in the development and maintenance of bone health. And in the pre-pregnancy and during pregnancy, the fetus receives its nutrition from the maternal sources. And when completing the diet history, then you take the diet recall. During preconceptional counseling, it is very, very important to ask about calcium consumption in food. It is also calcium to assess the woman's overall calcium intake. If dietary resource, if the dietary resource are inadequate, you have to give the oral supplementation with calcium, 1,000 milligram, and vitamin D is recommended. These are the various calcium-rich food we advise, and you can note here the sesame food and the almonds are also a rich source of calcium. Vitamin A, Dr. Bharti also come to the conceive. Sorry, the woman is planning to conceive. The pregnant woman should be counseled that this vitamin A supplementation above 700 microgram might be teratogenic and should be avoided in areas of vitamin A deficiency. And what WHO recommends is maximum safe dose of 10 1,000 international units or 25,000 weekly after the first 60 days of gestation. So you should avoid this vitamin A in the first trimester, as it is teratogenic, and even supplementation is associated with miscarriage and birth defects, even a craniofacial or cardiovascular or some abnormalities you will notice. And usually this vitamin A is given for the treating for the acne. So that should be avoided. So we all know dietary sources of vitamin A, that is a beta carotene, which should be included in our healthy diet, and that do not pose any risk of excessive intake. Iodine is an essential nutrient acquired through the diet. We know that the salt is fortified with the iodine, and it is essential for the thyroid hormone. And we know that the so much hypothyroid cases we get when we screen the patient during pregnancy. So iodine deficiency impairs the normal development of fetal CNS. Particularly, it is very important for the myelination. So it is a preferred strategy, and we all consume the iodized salt. The WHO recommends a daily iodine intake of 150 grams for adults and 200 grams for pregnant and lactating women. So these are others. You can just see this picture and see that tell the woman to consume that these are the iodine-rich foods. You can paste this during in your OPD also. The essential fatty acids are often discussed, and any woman who is planning for pregnancy should be advised to consume food which is rich in essential fatty acid, that is omega-3 as well as omega-6. The recent research has addressed the role of omega-3 fatty acid and EPA, that is uh, in the fetal cognitive and neurological development. Very, very important. So these are the essential fatty acids which are derived from the seafood, primarily from the fatty fish. And this fatty fish is known source of contaminants. So this is again you should take care of, that is mercury and persistent organic pollutants, particularly in the larger fish species. So you have to take care of these points also. So ACOG recommends that women planning to pregnancy can eat up to 2 to 3 servings a week. Those who are the fish, that is 8 to 12 ounces effects of mercury. So this is what they say, that the quality of fats is very important, and the relative proportion of the polyunsaturated fats than to increase the intake of total fats is also important. So it should be an optimal intake of DHA, which is necessary for the growth and development of brain and retina. So they should have adequate intake of this DHA. And this also plays an important role in the psychomotor and neurodevelopmental this development in the first trimester of life. The caffeine intake should not be more than 300 milligram per day. And they have done some studies, and they have found out that there is association of spontaneous abortion, low birth weight, and other adverse pregnancy outcome. They should be advised to lower the daily caffeine intake. Now, this is a simple chart. What is a target population? What is a nutrient required and the recommended dosages? And what does the evidence say? So, folic acid, iodine, iron, vitamin D, calcium, vitamin A. This is the FIGO, whatever the recommendations which are given. And these are the micronutrients and what nutritional interventions which are required in the preconceptional period. So what about proteins? Is diet enough? Because none of us, I don't think we are taking the proteins enough. So sometimes we have to supplement these proteins through various other nutritional interventions. You can ask them to consume much more dals and pulses. There are vegetarian sources of proteins as well. Like you can see here, apart from the non-vegetarian source, you can have eggs, milk, then cheese. All these are the sources of proteins you should ask them to take, or you can supplement them to various powders. So another thing I just wanted to point out is the nutrition and existing health conditions. The role of nutrition in chronic illnesses. Already the woman is hypertensive or diabetes in previous pregnancy, or she's already diabetic. These should be addressed. So metabolic syndromes are very common, and they require the medical nutrition therapy as a part of their preconception care itself. There are acute conditions such as anemia, which are treated with the diet and medication, and other conditions like epilepsy. There are various immunocompromised conditions like HIV. They require medication that may also alter the nutritional status. Like epilepsy, always we find that there is a folic acid deficiency. Some of the high-risk pregnancy conditions like preterm birth, gestational diabetes, hypertension may reoccur in subsequent pregnancy. So several of these adverse health conditions have nutritional component which should be addressed between subsequent pregnancy, even during that pregnancy. So this should be the nutrition, these are the nutritional advice for the specific conditions during preconception. So there should be a proper counseling for the balanced and diverse diet. So whatever available with that family, you have to say that, you have to tell them, and sometimes you have to supplement them. So it all depends on the social reforms as well. So iron and folic acid supplementation as per the guidelines for the anemic woman should be supplemented. So this is how we can break the intergenerational of malnutrition, and others inadequate nutrition before conception is the culprit. So we have to focus, and even UNICEF has got a focus on first 1,000 days as an entry point. So preconceptionally, iron and folic acid supplementation, deworming, fortification, supplementation of iodized salt, adequate proteins, treating of various conditions already if they coexist, and most important is a counseling. So these are the ICMR recommended dietary allowance. It has been revised by ICMR, and you can go through they are available on the website. So in conclusion, the healthy diet is very essential for the optimal pregnancy and fetal outcome. Information on healthy, well-balanced diet that includes vegetables and fruits should be given to all mothers, especially those embarking on a pregnancy. As a component of preconception care, issues regarding nutritious diet, weight gain, and dietary supplements should be addressed. So these are the various key messages, like poor nutritional status of mothers before and during pregnancy extend throughout the life course, and it leads to the intergenerational vicious cycle of undernutrition targeted to a woman of childbearing age in the period before at least 2 years and between consecutive pregnancies we should address. And availability of the adequate amount of nutrient just before conception and during early pregnancy may influence the critical processes of development. So neutral reproductive health services, including family planning, especially healthy timing and spacing of pregnancy, as well as women's empowerment as a part of holistic preconception care services. These have been addressed and must, as the policies also are very important, the government policies, their implementation, and the counseling part. This is very important. This is very important book I brought during my tenure as a Food and Drug and Medical Surgical Equipment Committee. I'm very, very thankful to Dr. Alpesh Gandhi as an President Foxy then. And this book also got a Best Book Award, and it contains all the nutrition part across the women's ages. And I also seek your blessings for the post of Vice President Foxy South Zone. And I thank KSOGA family and others for giving me a support. And I extend again a warm welcome to all the faculties who are again are participating in the very important panel discussion which Dr. Chennai is taking on. Thank you very much. Thank you very much again. Thank you.
Thank you, Dr. Vidya Tobi ma'am, for that standard presentation. You have covered everything on micro and macronutrients. Yes, I wanted to mention regarding the book. That was an excellent book that you have distributed. We have read the book. That's an excellent book. And no wonder you got the award for your committee. And I wish you all the best for your future endeavors. Thank you for the good knowledge.
Thank you so much, Aruna Madam, for chairing the session, and thank you for your inputs. Thank you, Vidya Tobi Madam, for a wonderful talk. Now the session 1 ends and session 2 starts.
Yeah,
I call upon Dr. Rachna to take over. Yes,
We
madam.
thank Dr. Aruna Suman for
Thank
chairing.
you, Shobha.
We wish her also all the best in her endeavor as she is
Thank
also
you
going
for the opportunity.
for Practical Obstetrics Committee, right, Aruna?
Yes.
Yeah.
Thank you so
Wish you
much.
all the best.
Thank you. All the best too.
Thank you, Vidya ma'am, for the excellent talk, and thank you, Bharti ma'am. That was a great session we had. Now we'll start with the session 2. That is the panel discussion. And for this panel, I welcome our expert, Dr. Sampath Kumari ma'am. So ma'am is going to be, and the chairpersons for this talk is Dr. Mahesh Korigal sir and Dr. Krishna Shashi sir. Are both of them there, ma'am? Krishna Shashi sir and
Yeah.
I'm
yeah.
There. Sir is there.
I'll start with the reading of the expert, Dr. Sampath Kumari ma'am's CV. Ma'am is there?
Yeah. She's there.
She's there.
Ma'am has been the Foxy Vice President for the year 2022, and she's been the Senate member of Tamil Nadu Dr. MGR Medical University. She's been the National Corresponding Editor for Jogi and Founder Secretary of Tamil Nadu OB-GYN Association. She's been the retired Deputy Director for the Institute of OB-GYN, Madras Medical College, Chennai. She's been the President for the Board of Studies, OBG, Tamil Nadu Dr. MGR Medical University from the year 2015 to 19. She's been the chairperson of Foxy Adolescent Health Committee 2016 to 18. And she's been the first ICOJ Distinguished DC member. She's got the award in the year 2021. She's also active in IMA. She's been the Women Doctors Wing Chairperson, IMA Chennai South. And she's also won the IMA National President's Award and IMA Tamil Nadu State Award 2021. I welcome you, ma'am. It's really an honor to have you as the expert for the panel. I request you to introduce the chairpersons of today's program, ma'am. Shobha, you're going to introduce Dr. Mahesh Korigal?
Rachna?
Yeah. Hello.
Hello, Rachna.
Yeah.
You want me to introduce? Sampath madam will introduce, no, Doctor?
Yes.
Yeah, Sampath ma'am.
Okay. Who are chairpersons? Can I have the CV of chairpersons?
Yeah.
Please put up the CV now.
First of all, thanks to Dr. Vidya Topi and Bharati and the entire KSOGA team and Chinmay. She is the chairperson of Perinatology Committee organizing a wonderful PM. See, now for this the case discussions, we have the moderator as Chinmay Ratha and the chairpersons being Dr. Mahesh. Dr. Mahesh is the Director of Senior Infertility and IVF Specialist Consultant, Nova IVF Fertility, Bangalore. And she is practicing infertility and IVF practice for more than 17 years. Current EC member of KSOGA South Zone 23 to 25, Vice President-elect of BSOG, Treasurer of Bangalore Society 22 to 23, Secretary of Bangalore Society 21 to 22, Chairperson of KSOGA Reproductive Endocrinology Committee 21 to 22, current EC member of Karnataka ISA chapter, member of Foxy Endoscopy Committee, member of many other federations and societies. He has a teaching position, former assistant professor, and he has a fellowship program in reproductive medicine and a good academic excellence. Welcome, sir, Dr. Mahesh. And next one is
Dr. Krishna Shashi.
Dr. Sri Krishna Shashi. Doctor has been an eminent personality in the field of OG, and he was the foundation member of Foxy Anantapur Society, currently executing the duties of Secretary, AOGS, and ethical team member of RDT. He was a pioneer in conducting buttonhole tubectomies. He has done more than 1 lakh laparoscopic tubectomy, and as a part of national and the state sterilization program, he has been rewarded state award for his excellence 3 consecutive years, 2015, 16, and 17, and has been credited with the best doctor on district level for 6 times and was awarded Foxy Dira Award, Stop Violence Against Women, conducted by Foxy FIGO 2022. Welcome, Dr. Sri Krishna Shashi.
Thank you, madam.
Now the stage is to Dr. Chinmay, I think.
Yeah. Today's moderator for the panel discussion is Dr. Chinmay Ratha, ma'am. and she is the chairperson for Perinatology Committee. I request Mahesh sir to read a CV.
It's okay, sir. I think you can introduce our panelists.
It is my pleasure to introduce Dr. Chinmay Ratha. Madam is Director of Resolution Fetal Medicine and Research Institute, Senior Consultant Fetal Medicine Research Hospital, Hyderabad, Chairperson Perinatology Committee FOXI of 21 to 24. She is President of SFM Telangana Chapter, Member of Scientific Committee IMA Telangana, Member of IRC, AICG, RCOG, South Zone, and Madam is a approved trainer for Fetal Medicine Foundation of UK, and Madam has won CS Dawn Prize recently in AICOG Hyderabad, in which we both presented paper. And Professor Kamal Bakshi Oration in Fetal Medicine in New Delhi in 23, Shirodkar Oration Award in Solapur Society in 22, Asia GCC Award for Excellence in Healthcare Leadership in 21,
Let's move
APJ
on.
Abdul Kalam Award for Service during Pandemic in 21, and Rajat Ray for Fetal Medicine Award
It's
in
okay.
19. So many list of analyst achievement, and we are happy to have you as a moderator today. Welcome.
Thank you so much, sir. And at the outset, I would like to thank Vidya Thobi ma'am and Bharti madam for this opportunity to be here with KSOGA. It's always nice to have a very academically charged forum for these kind of discussions. Sampath Kumari ma'am, our eminent senior and our vice president last year. It's really nice to have all of you here, and I see so many of our friendly faces. We have a very eminent panel of experts today, starting from Kashmir to lower down south, and therefore we are looking forward to a lot of inputs. I think we should have the CVs of our panelists, please, so that we can introduce them before we get on to the actual topic of the thing. So we have Dr. Captain T. Seshashai, who's currently working as Professor of OBG in Nellore. And I just spoke to sir in the morning. He has a lot of experience in the public sector institutes, and I'm sure we will get insights about, how genetics is handled in the medical colleges versus what we do in private sector. Because as you can see, he has not only worked in medical colleges, but he has also worked as the president of the Chittoor OBG Society, and he has been a Lions Club member, and therefore he has a very, very strong experience in not only teaching but also in social activism, where you will understand that the impact of all these genetic problems has social as well as medical repercussions. Welcome, sir, to our panel. And his very nice motto is love and serve. So we are looking forward to meeting you, sir. We also have with us Dr. Shehnaz Taim from Kashmir, and she is the ex-professor and HOD of the GMC in Srinagar, and she conducted the first ever Yuva Foxy program in J&K in 2015, and that would have been a really brave thing to do. And we are so glad that Kashmir is now getting part of our regular activities, and we are seeing more participation from there. But we are very eagerly waiting to hear from you what you have to say with regard to the genetic problems in Kashmir and how it impacts your clinical practice. So Madam has started a sonology wing in the main maternity hospital of the state Lal Ded hospital, and we welcome you into this panel. We also have with us Dr. Nikhat Firdaus, again a very, very eminent.
संतरा के ऊपर रखबे, ओकरा ऊपर भारी नहीं धो देबे.
Please mute others.
So Dr. Nikhat again has just superannuated from the GMC Srinagar. I spoke with her, and madam is now more into private practice, but she worked in an extremely busy unit where she said it was almost like 150 admissions per day. So coming from that kind of a busy unit and having a teaching experience of 40 years, trained in endoscopy, being a PG examiner and teacher, we are looking forward to get madam's inputs on genetics as well. I think Dr. Mahesh is not able to join us because of some emergency. I'm not sure. Have you joined, sir? So he belongs to Singrauli, which is a very nice place which has coal mines, but I'm not sure he has actually joined us. And we also have Dr. Sri Lakshmi.
Dr. Sri Lakshmi is a very, very close colleague from Karnataka who has worked on, as you can see, 8 awards, 38 publications, 2 orations, worked on ICMR projects, an extremely illustrious alumni of the KMC Manipal, and has held many, many prestigious positions in KSOGA, editor, national corresponding editor of Jogi. And she does work in fetal medicine. So she is my, professional cousin there who's going to help us take forward all the cases in this panel. So thank you very much and welcome all of you to the panel. And I will just share my slides now. So when Bharti Madam said that we will do something on prenatal discussions, we thought we will take prenatal genetic dilemmas, because every time there is a report of some genetic condition, we are in a dilemma whether we should test, whether we should not test. We are a country where we are constantly battling the fear of the cost of the investigation. And again, should once the investigation report is adverse, we don't know what to do. So we will start with a very simple case, that this is a lady who is the second gravida. And when you take basic history in the outpatient department, you find out that it's a consanguineous couple and they have a first child who is receiving repeated blood transfusions. So I will start with Tirupati sir. This is the first time she has come to your OPD, and what you see her in the history, it says one child is having repeated blood transfusions. What crosses your mind and how will you plan her further care?
Thank you, ma'am. I'm very happy to see all of you. And really, I'm very grateful those who are participants in examiners group. Nearly 3,000 participants all over the India. Every town they are participating. I thank everyone, especially Sampath Kumari, Dr. Vijay Thobe madam, and Bharati Rajsekhar. They helped a lot in doing everything. Regarding this genetic counseling and other things, we have to plan further care at 12 weeks. And really, they are not coming that easy most of the time. So we have to see the case and detailed history we have to take. Then she had in the first gravida female baby 3 years age. They did LSCS with history and admission in the hospital at the age of 9 months. The baby is admitted with respiratory tract infections and diagnosed as beta thalassemia, followed by history of multiple blood transfusions. The baby was found to be homozygous for C92 plus 5G beta thalassemia major. So we have to go further.
So, sir, when you see a lady and the history says that there is repeated blood transfusions, so that should strike us that why repeated blood transfusions? Because the first child can be anemic, but if it is nutritional anemia or anything else, it will get corrected with some treatment at least once, and then there will be some diet supplementation. But when they say repeated blood transfusions, it is a need for taking a detailed history. So that is one of the first things in genetics, that you start with the history. History gives the clue. And then when you go on and investigate, you will find your final answer. So in this case, when they said that the girl is receiving multiple blood transfusions, it was referred to a geneticist, and the geneticist worked out the child, and the child had a homozygous mutation in the gene which causes thalassemia. So this child is homozygous, which means both of its alleles are affected, and therefore the child is having thalassemia. Whereas the parents are heterozygous, and therefore they are just carriers, and they are otherwise normal in society, but they can have children who are abnormal. So now our diagnosis is confirmed. We know that this child has thalassemia and there is a recurrence risk of 25%. So Dr. Shahnaz, madam, do you think we can directly go and test this fetus, because there is a 25% chance of recurrence? Do you think we can directly go and test, or we need to do some other test before testing the fetus? Shahnaz madam, you need to unmute yourself, please.
Hello?
हाँ जी, अभी सुनाई दे रहे हैं, हाँ.
You see, we now know that definitely it's a final diagnosis that the first index child is affected with thalassemia major. We have to know the carrier status of the couple, the mother and father. Accordingly, we can then decide to go for testing of the baby which the lady is carrying at the moment. By going, we can plan a chorion villus sampling and then consider whether this baby is also affected.
So you feel that it is better to do the parental carrier testing, because without that, if we proceed, we will be a little lost in what we are looking for. So the first
Exactly.
child has the homozygous condition, and it was always good to check for the parents whether they are carriers. So you start with an HPLC and then move on and do a mutation matching. So now she is 12 weeks and we have decided we are going to plan a chorionic villus sampling. Now, if you remember, we also discussed that this is a consanguineous couple. So when there are consanguineous couples, this is one gene which is common, but we don't know whether other genes are common or not. Thalassemia is definitely something we are looking for, but it is 2024. We have so many things we can do. So suddenly the idea strikes you that why should I look only for thalassemia? Why don't I do what is called a whole exome sequencing? That is really fancy, you know. If you say whole
That
exome,
would be better. That would be better.
so you
Because
feel
we
that would
want to
be
be on
better.
the firmer ground whether this
No.
baby is affected because of the consanguinity. The other problems may crop up. So better
madam,
would be to go
let's
for.
hold your thought there. I agree, because I have sold you the idea of whole exome sequencing and you feel that is a better idea. Let me ask our colleague Dr. Sri Lakshmi. You have this couple who are consanguineous and first child has thalassemia major. You are now planning a CVS. Do you want to do only the mutation matching or do you want to do a whole exome sequencing?
Yes, ma'am. That is a very interesting question, actually. When we have already a phenotype and genotype correlation, that there is an affected child whose phenotype has correlated with the genotype. So we need to do only Sanger testing. That is only this mutation on chorionic villus sampling, and maybe we can offer whole exome sequencing or the carrier screening of the couple as a consanguineous marriage. But definitely on chorionic villus sampling, whole exome may not be required.
Okay, thank you for that answer. And if our audience is listening carefully, you would have realized that there are 2 points of view here. Dr. Shahnaz feels, why don't we check everything? Because they are consanguineous, they may be having more than one genetic condition which is common. And therefore, when we are going to do such a big test, why are we only limiting ourselves to just the mutation testing for the thalassemia? Why don't we do everything? Dr. Sri Lakshmi was very careful. She did not say don't do whole exome. She said, I would like to also do what is called couple carrier screening. So, Dr. Sri Lakshmi, can you just tell me what is your apprehension in doing whole exome directly?
My whole apprehension is that word called variants of unknown significance. See, what is very important about exome sequencing is we have to do phenotype genotype correlation. We don't have the baby in our hand. We just have black and white images, the gray images of ultrasound. We don't know whether there is a depressed nose, low set ears, and so many morphological features which are unfunctional part of the brain and the heart. We don't know. We just know the structure, that corpus callosum is there, cerebrum is there, cerebellum is there. What is the function of that? We don't know. So when we have so much of question marks, there is no point doing a whole exome sequencing, putting the patient more into confusion rather than the clarity. Here we have a hit position. We have a thalassemia major. We have proved that by genotype, and let us give.
Okay, we got your point. So what if the couple asks you, are you sure? Can there be any other problem in our baby? What would you say?
Yes, that is a very, very, very rare situation. Having two single gene disorders is really unfortunate event which happens. First of all, single gene disorders are very rare. It is only about like one in more
So
than.
let's not go into that. The point is, once they are consanguineous, there can be,
There
the
can be,
rarity
there
is
can be.
rarity because the rarity is reported in like world literature. But the level of consanguinity we have in our country, in our communities, that can be there, and we do see a lot of people with multiple mutations. So you are saying because it is rare, you will hold on to this. Now, are all the panelists on board that this is fine? Shahnaz madam, are you happy with this, that we are just going to do thalassemia and consider the rest of it rare and therefore not talk about it? Or do you want to give them some information more than whatever we have discussed so far?
Ma'am, but we need to do a karyotype.
Let Dr. Shahnaz give us our.
Now that we are doing an invasive procedure, our baby is already affected with this. The first baby is already affected with thalassemia and they are consanguineous. There is consanguinity. I would rather go for whole exome sequencing and see whether any other complication is also there. Any other mutation is also there. I stand by my statement.
I think both the experts have merit in what they are saying. So the ideal thing here would have been to do what is called a preconceptional workup. Why is Dr. Srilakshmi worried about doing the whole exome? Suppose we get a variant of uncertain significance. And then we will not be in a situation to either reassure them or scare them. But that problem we have right now is we don't have time because we are already at 12 weeks and we need a quick answer. If we do a whole exome and find a variation of uncertain significance, we have to go back and check the parents. And for that, we don't have time. So in this kind of a situation, the ideal thing would have been to do what is called trio analysis, where you check the parents as well as the fetus at the same time and get all your information. But the problem is cost. You have to do 3 tests for the cost of 1. And therefore, in any genetic condition, the ideal thing would be to do a preconceptional workup. Now, the other thing is whether we should be also doing aneuploidy since we are anyway doing CVS. I'll ask Nikat madam this. Nikat madam, we are already doing a CVS here. So for the mutations we've understood, but should we also check for aneuploidy?
Good, good evening. Yes, we can check for aneuploidy because first trimester fetal testing. The only thing which puts me to tell you that aneuploidy should be done because this is a consanguineous marriage. Consanguinity is one, and as I was talking to you in the morning in your setup, the consanguinity is very high, right? That is one thing which tells me. And because when we do aneuploidy studies, which is normally we are doing NT-NB and a dual marker up to 12 weeks, right? So, but the patient is coming at 12 weeks. So I think we can go up to dual marker and NT in up to 13 weeks. So that can give us some clue to the aneuploidies.
Absolutely. And here, since we are anyway doing an invasive test, so when we do the NT-NB and dual marker, our aim is if it is high risk, then we go ahead and do an invasive test. But this is a situation where under any circumstances, we have to do an invasive test. So it may be useful to just use some of that DNA and check out the aneuploidy so that we are not stuck with, markers and all that confusion later on after having done a test for invasive. So I think we are clear here that since it is consanguineous, we will try and check as many possible conditions, but rationally. We won't do random whole exome. We will do a parental testing along with the whole exome so that we get a full information, which is known as trio analysis. But suppose we had the opportunity to see this patient before she got pregnant, we would have offered preconception counseling. So in this case, the CVS was done and the child was found to be unfortunately homozygous for thalassemia major again. And therefore, this also had to be terminated. But every time she gets pregnant, she has a 25% chance of this situation, but a 75% chance of still having a viable baby. And that we will be looking for later. So what is important here is index child workup by genotype, screen every woman because thalassemia is pretty common. And
Pretty
I
common.
was talking to Nikat madam, she said not that common in that area, but I think it is depending on the population. And now, as you have realized, there's so much mixing of populations that it is always better. HPLC costs hardly 500 rupees, and many of the government organizations, as well as many of the in our city, the Thalassemia Society offers it for 200 rupees. So we should just go ahead and check everybody with an HPLC. And whenever we have a consanguineous couple with some genetic issue, doing a couple carrier screening helps. That is what Dr. Sri Lakshmi was alluding to, that we can do a couple carrier screening and prevent the burden of treating genetic diseases. So now we move to case 2, where we have a non-consanguineous couple. This time there is no consanguinity. She is a second gravida, and the first time there was a termination of pregnancy because she had some kind of an anomaly in the fetus, which was a bilateral absent radius short ulna, and nothing was evaluated. This time she forgot, she did not check her early pregnancy investigations, and she's come directly at 15 weeks. Nikat madam, how will you counsel her as an obstetrician now?
What are the, she's para 2. Can I go to the history again?
Madam, non-consanguineous couple. The previous time she has some report which says that there was probably some abnormality in the limb, bilateral absent radius, query short ulna, query halt oram syndrome, but nothing evaluated, no genetic evaluation done. And they terminated the pregnancy because of that anomaly.
Okay.
Non-consanguineous.
So the pregnancy was terminated because of absence of radius, but no consanguinity at 15 weeks. We still have time. We still have time. We have ultrasound as one of our, we have 3D and we have so many ultrasound can give us a very good clue.
Yes, I'm so glad that you said that, because everybody gets worried. She didn't have NT scan, she didn't have anything. That's okay. We still have time. That is the approach which all experienced obstetricians should take. That there is nothing that you have to alarm. Sorry?
Yes. We don't have to scare the patient. We don't have to, get disheartened, because we have lots of time, because as far as the termination of pregnancies, we still have time. We have 22 weeks. And now that the fetal DNA has come into existence, and the cost of which has gone, drastically down now. Initially, we would not afford it. So we have that thing also in our mind. We have ultrasound in our mind. One important thing is that there's no consanguinity, so partly few things are ruled out, right? So, but because there's a doubt, whenever there's a doubt, the benefit of doubt has to be given. If there's a doubt of the first baby and this baby, we may expect, because if we are doing carrier, this couple counseling, and 2 of them are positive for it, and the chances become 50% in the fetus to get, because 25% will be transmitted almost from both the parents, and the chance of the abnormality may be very high, 50%.
So,
right?
So what you correct. So because there is no consanguinity here, you have decided that maybe it's not genetic, and whatever you have seen in the history, you have reassured them that it's only 15 weeks. We'll first see on the ultrasound, then we will plan further. Even if you've missed the first trimester screening, we have not missed all the boards. We still have other methods of screening, and that's how we begin. So she is sent for a scan, which is a very reasonable thing to do, madam. I'm happy that you've sent her for a scan. But once you've decided, you've told her all these things, that we have seen everything, and we will do a scan-based follow-up plan. Now she comes for a scan, but unfortunately, what we see on the scan again is that there is no radius, and the ulna is also very short. So the forearms look extremely, extremely short, and they are malformed. Any of you who do scans will understand what I'm showing here. So there is a single bone in the forearm, and the hand looks completely abnormal. So we don't know what exactly was the problem last time, but it looks like a recurrence of the problem. So we don't have Dr. Mahesh here. I will ask Dr. Sri Lakshmi.
I would like
Yes,
to
ma'am.
say that if she has limb abnormalities again, then it's not the only limb abnormalities, because this halt arm syndrome, or which we even call as the heart hand syndrome, in the cardiac abnormalities would come up now. The cardiac
True, ma'am.
abnormalities would come up.
There is a lot of possibility of having other abnormalities. My point is, whatever is easiest to pick up at the 15-week scan, because in the previous scan also they had not commented, and here for the interest of the general public, what we are trying to bring about is, because it was non-consanguineous and a single abnormality, at the first instance we did not think of genetic condition. We reassured, we said let's go and see on the scan and we'll see whatever is happening. But the moment we do the scan, we find an abnormality which is similar to whatever was the pattern last time. This indicates that maybe there is a genetic origin, and therefore there is a similar recurrence. So even if they are non-consanguineous, there could be a genetic condition. Lesson number one.
Yes.
And lesson number two is, we don't have a genetic diagnosis, but it is obvious on the ultrasound.
Yes.
Now we have a non-consanguineous couple with a genetic condition which is manifesting on the ultrasound. What do we tell them? So Dr. Sri Lakshmi, would you like to take this? Dr. Mahesh is not there. Please fill in for him. No, unmute, please, unmute.
Hello, ma'am.
Yes.
Yes, as rightly pointed out, here the first clue is, although it is not a consanguineous marriage, we should still think of a genetic condition, because there is a recurrent, the same anomaly is there. So the first point is whether it is only limb abnormality or whether there can be a mental retardation, which is a very high burden for the patient. That information we may not be able to give properly prenatally, only by ultrasound. So there are two options. First one is, if patient wants to take a risk and wants to continue the pregnancy, then we have to offer her, if she's already 15 weeks, so we have to offer her amniocentesis, chromosomal microarray, and DNA storage as well. But if patient opts for a termination of pregnancy, she needs fetal autopsy, DNA storage, and complete genetic evaluation sequentially for chromosomal microarray, for if we don't get an answer, to go for a whole exome sequencing. This should be the ideal workup of this patient, and we should encourage her to go for a complete workup sequentially, because there is a recurrence and she doesn't have a good life, a healthy life child.
Excellent. So we got your point, which is very rational as a fetal medicine and a genetic person. I think I would like to bring in our expert here, Sampath Kumari Madam. You've done obstetrics through the ages, and you've seen everything in public sector, in private sector. Now we have a situation like this, non-consanguineous couple having something which may be a genetic condition, but it is such an obvious abnormality, because in this case, she missed her first trimester screening. But Dr. Sri Lakshmi, you will also agree that once we have this history, the next time she has an NT scan, we'll go look at the forearm very, very carefully.
Yes,
and
very
at 12
carefully.
to 13 weeks also, we can make out that forearm abnormality, isn't it?
Yes.
Now, this is a genetic condition in a non-consanguineous couple, which is presenting with an anomaly that can be seen at 12 weeks.
Yes.
So do we really need a genetic diagnosis here by a molecular testing? Because what will we do? If we have a molecular testing also, we'll test only at 12 weeks. So our expert, Sampath Kumari Madam, I really need your opinion here.
So, as you tell, I have been working with the government hospital setups in Delhi. See, this patient already, she missed the first trimester. Now, the second also, she is coming only at 15 weeks now.
Correct.
Yes. So, this patient daily requires the preconceptional counseling. In nowadays, in all hospitals, next to the antenatal ward, we have this counseling. At least by the NT scan. NT scan, nowadays, we don't advise for only the consanguineous or non-consanguineous. Nowadays, we go with the NT scan for all patients almost, because other things may be costly. This NT scan we can do in our medical college and hospital itself. So as you tell, with the NT scan, if there is the recurrence of this radius and ulna, straight away we can give the option to the patient, whether she can continue or whether she wants to be terminated. Whatever the patient decides, we will proceed, because they may not be in a position to do the genetic test and other tests. So this NT scan is really must during the preconceptional counseling. Suppose if she comes in the 15 weeks and you are doing the scan, again the same condition, radius and ulna, as far as our hospital situations concerned, they will go for termination only, and we will also do it.
Yes.
My opinion.
So I think being practical is also very important. Who wants to say something? Dr. Srilakshmi? Yeah.
Ma'am, yes, what the point put was, we can make out everything by an ultrasound? Why do a molecular testing? That is what is the question here. My point across is that these genetic conditions, they present in a varied way. There is variable penetrance and variable expression, incomplete penetrance and variable expression. So some genetic conditions, although they have the same genotype, they may not have the same phenotype at the next time. So it is very easy if the patient has again a limb abnormality next time, but if it is not there, if anything, something else phenotype comes, then we may be missing it. Yes, if
So
patient
I think, no, we got your point, and that is why I think what we have written here is that the condition has an ultrasound-based diagnosis. The inheritance pattern can be established with testing, but it will not change the plan in next pregnancy, because even if we do a genetic testing, we'll come to know at 12 weeks if the baby is normal or not based on the same phenotype. But like you said, there could be variable phenotype, and very often people don't accept just the geneticist or just the fetal medicine or the obstetric person giving this advice. So as Sampath Kumari madam said, this patient should have a very detailed preconceptional counseling where she should be told of all the options, and preferably by a geneticist. So now we do have people who are clinical geneticists, and they should give them this option that if you want, you test, because the parents are completely normal. And if this is happening, this may be an autosomal dominant condition, which could be a part of a gonadal mosaicism in one of the
Ma'am,
parents.
I would like to emphasize another point is that in prenatal counseling, I think we should be asking the detailed family history in the family, whether there is a close relative, whether the uncle or aunt or grandmother was affected by some genetic condition, and it is recommended by the geneticist only to formulate a pedigree tree of 3 generations.
Absolutely.
And then see,
Yes.
then see whether that is. I think that should be a part of such couples in the
No, no.
prenatal counseling.
Completely agree, madam. And that is why when the preconceptional counseling will be done by a trained geneticist, they will go through these protocols and they will be able to explain to the couple in that much detail, and that necessity of this testing will go across to the couples, because there are two things here. Not only that, we can definitely manage this by these ultrasound based diagnosis, but you know what will happen if it is actually a genetic condition, it will never get reported. And that is the reason we think that so many conditions are rare. They are not actually rare. They are rare because we are not reporting them, because we don't have that data with us right now. So doing all the tests also helps in getting the data. And of course, once we have the data, we can report it. But being in a poor country, sometimes there are reasons where we may have to, take a middle road because we cannot afford the extreme road. So my point of bringing about this case was there are many ways to reach a rational care for the patient in this pregnancy. An ideal situation would be where we can get data, we can do genetic testing, we can do all the correct counseling and correct management for the patient. But there is a practical way where it is presenting by ultrasound diagnosis. So we can also follow by ultrasound and give them at least a good outcome. Because like we say always in perinatology, we may not be able to cure, but we can definitely care. So we go to the third case here, where we have Mr. and Mrs. Y, who are fourth time pregnant, and they have one child who was a 2.5 kg male, but global developmental delay. And at 2 years, when an MRI was done, they found that there is no corpus callosum. The second pregnancy was a missed miscarriage. The third pregnancy, there was colpocephaly and signs of corpus callosum agenesis at 20 weeks, and the fetus was terminated. Again, no genetic evaluation done. And this is very common history. Till 2020, the cost was so high that hardly people went for genetic testing. If the condition was so bad, like obviously there's no corpus callosum, there's ventriculomegaly, it's going to have a poor outcome, they just terminate the pregnancy. So now you have a consanguineous couple, Corpus callosum agenesis in 2 pregnancies, similar pattern, but molecular diagnosis not known. So, Dr. Srilakshmi, what do we do now?
Yes, ma'am. This is actually the most common scenario that we come across, that history of global developmental delay in the previous pregnancies, and no workup is done in the baby, and baby is also not alive for us. And unfortunately, what happens, even the baby's DNA will not be stored. Very few times they have the superstition of keeping an umbilical cord somewhere and some pieces, but that is also very not seen many a times. So when this happens, it take as much of history and as much of reports. For example, many a times they may be having a neurosonogram, MRI reports, because each small details, intricate details of the brain matters. So note down all the things and go for a carrier screening. Carrier screening, nothing but a whole exome sequencing of both husband and wife. And if it is genetic testing, if it is a neurodevelopmental delay because of single gene autosomal recessive disorder, definitely we will get a carrier status, that is heterozygous state in the both parents. With that, we will be able to offer definite prenatal diagnosis. If they are early, it is by 12 weeks chorionicular sampling. If it is late, by amniocentesis, then we can just go for definite Sanger testing for the baby in the fetus in the utero.
So, Nikhat madam, do you think this will be acceptable to your couples?
Yes.
What Dr. Srilakshmi has explained, that is very nice. It sounds very good. But,
Very
whenever
nicely explained. And rather than giving the burden of this two colossal problems with consanguinity, you expect a very high malformed, or I can say congenital abnormal baby, and it will be a huge burden on the parents. Cannot,
Yes.
I don't think, cannot take it. I would just stop here by saying termination is to be offered.
No, termination is okay. For this pregnancy, termination makes sense. But now, when we want to do a testing, in the first time there was no. Would you do a couple carrier screening? Do you think couples will accept? You have worked in all setups. So, what is the acceptance of genetic tests?
Yes,
Don't they say it is
one
very
is
expensive?
depending upon the availability, affordability, and of course, with two mishaps, and you know how desperate they are about the children, to have a normal baby. So I think if counseled properly, they will accept.
So, if counseled properly is the underlying sentence.
Yeah.
Because when we talk to our patients, many times when they say, "Humne double marker nahi karaya," why didn't you do it? Madam said, not necessary. You want, you do it. You don't want, you don't do it. So, every screening is voluntary. By definition, screening is a voluntary activity. But everything is voluntary. Attending this webinar is voluntary, studying is voluntary, everything is voluntary. So the way we are explaining things makes a difference in the way we take the decision. So
the quality of
And
counseling
of course,
is important.
genetic counselors are there, as we are rightly talking, genetic counselor, because it is very difficult to explain. I say a proper counseling, but counseling has to be, tremendous. And because there are always false negatives, false positives, so you can't be 100% sure about everything. So I think the couple will accept.
So, madam, they did accept, and we went ahead and checked for the parents. But now we find that no, I think this was in the this thing only. This was in the fetus only. The parents were found to be carriers of variations of uncertain significance. So, that is what Dr. Sri Lakshmi was also saying, variations of uncertain significance. So when this word comes, variation of uncertain significance, I just want to know, Shahnaz madam, are you dealing with genetic reports at any point? Do you get this term in your clinical practice?
I have never. This kind of reporting I have never seen.
Lucky.
Variants of unknown significance.
Sampath madam, are you seeing these reports sometimes?
Oh, I have not seen.
No, then you are lucky, because by the time they come to you, some fetal medicine doctor has probably
You would
cleaned
have
it for
gone
you.
to some expert of fetal medicine.
So, Sri Lakshmi madam, do you see this very often?
Yes, ma'am. That is the biggest headache. And every morning when I get up, I like today no VUS. Yeah, this is the scenario. Yes, VUS is the biggest thing. How to approach a VUS? The first one is sit down yourself, go to online Mendelian inheritance and man, go through the phenotype and the genotype, how far they are correlating. Then most of the times you will be able to make out whether it is a benign or a pathogenic. Number one. Number two, sit with your friends, like collaborators, ask them whether they have come across conditions like this, like a microcephaly, all the phenotypic features, corpus callosal agenesis, whether they are having this kind of mutation. So many a times they do come up, yes, we had. So if one or two comes like that, then probably you are dealing with a pathogenic gene mutation. But the thing is, it is not yet labeled as likely pathogenic mutation in the lab. So what happens is, for this scenario, she is already 16 weeks pregnant, and you get the report like this. You explain the couple. Most of the times, we will be able to do this Sanger testing and do VUS, but you have to take a chance and keep that.
So
all
let me
data.
just stop you here. Suppose we get the VOUS.
Yes.
Is a VOUS, is a variation of uncertain significance enough for us to plan a CVS?
Yes, after all this small research, if you are convinced that it may be a pathogenic or likely pathogenic, it is still explaining the small possibility of missing the data and do a CVS.
So, basically, I'm sorry, I had to take that call. So right now she's 13 weeks and NT scan shows abnormal filling of the choroid plexus. And in view of the previous history and consanguinity, the couple were counseled about the present findings and the option of waiting and reassessment at 16 weeks. And again, by the time they did the target mutation matching, and they got the same findings, and at the same time, they found the fetus was also affected. So
Yes.
although this was a variation of uncertain significance, because of the matching of the phenotype to whatever was the genotype. Now let us tell the audience that when we say uncertain significance, that is only lack of data. There are not enough cases that have been reported with the same genotype phenotype correlation, why it is classified as uncertain significance. So the more we will check and find this correlation and report it, then gradually the classification will change. So the same mutation in 2023 might be uncertain, but in 2024 might become either benign or pathogenic. So that way the genetic information also evolves. And like Dr. Srilakshmi said, there is the online Mendelian inheritance in man. There is a free website which you can go and check for the genotype phenotype correlation. So Shahnaz madam, would you just like to kind of summarize it for us? What did we learn from this case?
Just a second.
Yes, madam.
Can you just excuse me? I'm going beyond time. I have to fly tomorrow and I have an urgent. I'm really missing the,
Yeah, we'll
discussion.
miss you,
I
ma'am.
don't want to, but if my this phone works, I'm carrying it along. I may continue.
Thank you,
Sure.
Dr. Nigat
Thank
ma'am.
you so
Thank you
much,
very
ma'am.
much. And your presence gave us a lot of inputs of what is happening in the northern.
No, I'll still try. I'll still try. My video is on.
Yes, madam.
But
yes, please.
No
I'll
problem, ma'am.
just,
We'd love to have you again.
if I'm on, I'll just be a part of it.
Sure, ma'am. Sure, ma'am. Thank
I'm
you.
flying to Karnataka tomorrow.
Bangalore, madam?
Yeah, I'm tomorrow coming to your place.
Okay.
And I have some very important work this time.
Okay, ma'am.
I'll still try to be online.
Thank you, ma'am. Thank you, ma'am.
Thank you very
Okay,
much, madam.
thank you.
Thank you, ma'am. What I learned from this discussion is that in spite of getting this term of VOUS by the way of reporting, I should not lose my heart and go on being in touch and go on giving my inputs and maybe what is known today with my cooperation and with my involvement in the reporting, things may get clearer in the future.
And definitely we should report whatever we can and test whatever we can. And whenever possible, we should do a preconceptional workup and at least basic screening for genetic conditions. Sampath madam, some of the common genetic conditions like cystic fibrosis, SMA, thalassemia, we want all women to be screened for this in the preconception period. Do you think it's a practical suggestion?
Very
Yes,
much,
Chinmay,
very
after
much.
listening to this repeated conception with the problems, I think we should give the options to the patient. All the things have to be screened. Now I thought of telling Chinmay, see,
Yes,
you
ma'am.
should, talking with the fetal medicine people, no, you should come to the general logician and we ask, casually I will tell, if you want, you do, otherwise, nowadays, now I think we should not tell like that. So all the important things we can prevent, no. So all, whichever
Absolutely.
is possible, it has to be screened. The patient should think of their affordability. So now just I was thinking, you fetal medicine people come to the general logicians and talk the basic things. Rather than this, not everything should be done. We think that it is not at all necessary. See, but one case, it's also a problem, no? So nowadays,
Absolutely.
hereafter, I will not tell, don't do. You have to do it. That's the way we should talk to the patients. Definitely.
Absolutely, ma'am. I think you just hit the nail on the head that it is something that we have to tell the parents that if you don't do it, it's a considered decision and your responsibility. So you want to do it, do it. You don't want to do it. My information, my job as a doctor is to give the information that this test is available. The importance of this test is you will get this information. If that information is important for you, please do it. If not, take your considered decision. So
Right.
what are our common prenatal dilemmas in prenatal genetics? This was my question to Dr. Mahesh, but I think we'll just run it across maybe our chairpersons can come in here because we have Dr. Mahesh here as a chairperson and he does a lot of, pre-conception, pre-implantation genetics. So that's at an even higher level. So Dr. Mahesh, do you come across problems which are dilemmas? Which are the cases which you actually choose for PGT or you tell them it's okay, prenatal will do?
See, if there is a known disease, already known disease in the family, so that is something that we would like to rule out. Or any recurrent miscarriages, or any of the patients with who have come with the previous recurrent pregnancy losses below 12 weeks. They are some of the patients who would like to definitely do a genetic testing. Or there are some autosomal recessive or autosomal dominant conditions we already know those can be tested by genetic testing. It could be a PGTA if we don't know, we just wanted to screen, or PGTM if you are looking for a monosomy, or PGTSR. Based on the different indications, we have different pre-implantation genetic testing modalities which we regularly do it.
Okay,
So
so
accordingly,
let
I
me
think
just stop you there. So when you say pre-implantation, we are definitely dealing with IVF.
yes.
So one of the common dilemmas that people have when they have repeated genetic conditions is, should we go for IVF so that we can, screen at that level? Do you think
Yes.
that's a rational thought?
Yes. See, there are two options. See, for the example, the first case we discussed, there is a recurrence chance of 25%. So there are diseases which are autosomal recessive or has some kind of a recurrence risk. So these are the kinds of patients definitely, instead of going into a depression and pain and the not only a psychological, physical, financial pain of losing a baby, it is better if we can find it out earlier before she get pregnant. So that is the concept, or that's the idea of doing a pre-implantation genetic testing. Find out, do an IVF, and then put it. Yes, I understand the cost would be a factor, but then if the cost is not a factor, then yes, this is the most ideal route to go ahead.
So that is another paradigm that when we want to test, we can test for the way we are testing now, or we can go on and wait at some point and think of a different method of reproduction where we can do a pre-implantation testing and therefore avoid the situation where you need a termination. Although even after that, prenatal testing is done to confirm, but the chances of getting normal results are high at that case. So the dilemmas in offering tests are whom to test, what to test, when to test. There are many ifs and buts, how to counsel when we get the results, what to do if there are non-specific results. And in some cases, this preconceptional carrier test will help. So understanding these basic inheritance patterns, like Sampat Madam said, as a general logician, somehow you think that you won't be able to explain this, but these are very, very simple things. And I think we have to increase this interaction between the people who work in core prenatal genetics work and the regular obstetricians, because these inheritance patterns will increase your awareness that what are the chances of this problem happening again. If it is autosomal recessive, 25% chance. If it is autosomal dominant, 50% chance. And that will encourage you also to work up for the genetic conditions, because after excellent obstetrics, if the child has a genetic disorder, the parents will never remember you that you avoided a postpartum hemorrhage, or you avoided a preterm delivery, or you avoided anything, because they will see the child every day and remember you for the wrong reasons. So, Dr. Sri Lakshmi, do you just want to summarize the learning points in any genetic case that we do?
Another thing is having a low mosaic in a PGT reporting, wherein we see a low mosaic embryo. Again, we are in a dilemma whether to do so. Even if the low mosaic embryo pregnant, then we'll have to again do prenatal.
So basically, what you are trying to say is genetics is not going to, it's like a Pandora's box. When you open it, one after the other, there will be too many dilemmas, ifs and buts. But that's the joy of learning. The more you go into detail, the more it becomes precise and nice and excellent. So, and do we have Dr. Krishna Sashi sir with us also? We would like to.
Dr. Krishna Sasi is there. Dr. Sheshasai had to leave for some other program.
No, Dr. Krishna Seshta is the other chairperson. No, does he want to give in any inputs at this point? And then Dr. Sri Lakshmi can summarize.
I don't see him here. I think sir is not there.
Yeah. No problem. Dr. Sri Lakshmi, do you want to summarize our learning points?
Yes, ma'am. So, when we are itself, we'll be able to point out there may be a genetic condition. Number one is a previous unexplained intrauterine death and a neonatal death, seizures with global developmental delay, and consanguineous marriages, or previous male children being dying that telling the X-linked recessive. These are the simple points that are hinting to you that it may be a genetic condition. Otherwise, we do get an anomalous babies, which will definitely tell us probably it is a genetic condition. With all these points in our mind in the history, then when we do a preconceptional counseling, especially for consanguineous marriage couples, which is very common, always offer carrier screening. And especially if it is a thalassemia belt, like in Shimoga, Hassan, Chitradurga, Haveri, and Davangere, this is a thalassemia endemic belt. And in Punjab, Gujarat, all these, it is worth doing a HPLC, that is a electrophoresis for thalassemia. And how about SMA and other genetic disorder? These are simple testing that can be done. Please don't think just because it is a genetic condition, it is a very high cost. Now it has become very affordable, approachable, and accurate as well. Even the exome sequencing reporting, it has become very affordable. So this is
basically, as much as we will use these tests, the affordability will improve. The availability will also increase. So I think there is a question in the chat box how to use POC for testing. So in any kinds of genetic conditions, when we don't have a prenatal sample and there is a POC situation, the POC can be sent just for DNA extraction. So if it is just POC, it's sent in normal saline. If it is blood, it can be sent in EDTA.
Yes.
It can be sent in EDTA, because heparinized tissue is like DNA interferes, DNA extraction interferes with heparin, and it cannot be done. So it has to be
Just
sent
a
in
second,
EDTA.
ma'am. I would like to interrupt. Once these products of conceptions are sent in normal saline, do we send those for a chromosomal microarray?
Madam, that is for DNA extraction. Once you have DNA, whatever you want to do with it, you can do. You can do microarray, you can do whole exome, you can do anything.
That's
Earlier,
what we want to know. No, it is
Sorry?
for genetic testing. No.
Yes, madam. So if we are doing something for chromosome analysis, we can do a chromosomal microarray. If we want to do genetic analysis, we can either test the mutation directly or do a exome sequencing. So
Fine.
it has to be sent in the EDTA or normal saline. So history taking is important, interpretation of letters, results, and like all our experts said, preconceptional, so that it gives you that advantage of time. And there is always a learning curve, like we all understood now. Sometimes even after the results are available, we won't be able to explain because there are variations of uncertain significance. Data generation is important, and that is why testing more and more and reporting our findings is very important, because then we'll know that this mutation is not pathogenic in this population. So, because I deal only with fetal medicine cases, every week we have at least 3 or 4 cases where we are struggling to find out whether this is actually pathogenic or not. And then we go back and test the parents, and something which has been reported pathogenic in the fetus is found in the parents who are otherwise normal. And then the report is changed to maybe it is not pathogenic. And then the geneticist will give us paragraphs of explanation of how things can have different expression. And therefore, genetics is going to be very, very complex. So one of the dilemmas is that we have to give them an answer whether it is going to be normal or not normal, and that is not always possible. So despite all our in knowledge, despite all our tests, there will be areas where there will be gray zones, and certain decisions have to be taken in the best interest of that particular clinical situation. So whenever we do preconceptional counseling, we should do a risk assessment, carrier screening, genetic education, because all these reports are less traumatic if we have done a pre-test counseling. And that is very, very important in genetics, so that they know what they are expecting beyond that. Informed decisions, psychological support, communication, and a regular, ongoing support throughout their reproductive journey. And I'm so glad that today we had a whole team of, clinical, a fetal medicine person. We had obstetricians from public sector, private sector, and an IVF specialist. So we would never have this entire multidisciplinary team sitting right there counseling a patient. But when we interact in these kind of forums, we take all the pearls of wisdom from everybody, and then, have a lot of matter to tell our patients tomorrow. And I think that is the whole purpose of this kind of a meeting, that today, wherever we are, we will be in a better state tomorrow. So before we close, one quick line from all our panelists, and then we will close forever. So Shahnaz, madam, take home message from you.
You see, when I was a student, way back 30 years back, there was no concept of doing genetic counseling or TIFA. That was something in the future. But nowadays, there is an explosion of information, and we, the gynecologists and obstetricians of that era, have to be abreast and upbeat and keep ourselves informed and increase our dimensions and be in touch with such webinars. Thank you very much for
Thank you, ma'am.
calling me.
So Sampath, madam, we'll close with your statement.
Stand
The
on
showstopper statement.
on a light of the sea,
methods
light of content.
Whatever the screening methods available should be given option to the patient. That is the take-home message today. It is their choice. We have to
So
tell them
informed decision by the patients. So with that, I think we will close our.
I have one last question I want to ask, ma'am.
Yes.
What I have faced practically is whenever I send products of conception, I don't get a conclusive report. But when I send for CVS and then terminate, I get a conclusive report. So what do you suggest, ma'am?
It depends. If the product of conception is a 6 weeks or an 8-week sample, you may sometimes get inconclusive report. But a bigger POC, it should not be a problem, because there's enough matter from there to extract DNA. Doing a CVS is always a good idea, because you can get clean cut sample. In fact, many of our patients come from districts and very, very remote areas. So they don't find it easy to come back with the POC. So for them, what we do is a free CVS. In our unit, we have a rule that if somebody is anyway going to terminate and they are just doing the procedure for the sake of collection of DNA, we do it free of cost for them. We just get the disposables and we do it. But it's not wrong to do. But then at the same time, with a bigger tissue sample, that should not be a problem. Sometimes because of infection and all, very, very small 6 weeks, 8 week samples, we may be able to face this problem. But Dr. Srilakshmi, you have any other input here? Muted, sorry. Unmute. Unmute yourself, please. We can't.
Unmute.
Able to unmute it.
No, our computer has decided not to unmute.
Yes. Yeah. Am I audible? Huh?
Yeah, yes.
Yes. When we are using the method of mifepristone and misoprostol for termination, there is a possibility of getting inconclusive reports and not able to store the DNA because that affects the placenta. That may be one of the reasons. And my take-home message for today is kindly store DNA in all the anomalous fetuses or any neonatal deaths or global developmental delay, baby has died. Just store the DNA, just costs about 1,000 rupees, and they offer the storage of DNA from 1 year and even up to, you can extend it to 5 years. So you can just take back the DNA and do a complete workup when it is needed, because one time patient may disagree, but if it has happened again, then definitely patient tries to get all the genetic testing done. So storage of the DNA is the most important thing for any unexplained situation.
So ideally index case workup, and just in case, like Dr. Rachna said, suppose you tried your best and you couldn't get it, then preconception couple carrier screening would be the next option. So that, you know, at every point we should have an attitude to give them solutions. If we keep telling them problems, patients are going to feel very helpless in that whole situation. So with that, I think we finish our panel. Thank you very much, Bharti Madam. Thank you so much, our eminent panelists.
Thank you so much.
Chinmayi, I'm extremely thankful to you for this excellent session, and the panelists, Dr. Shahnaz Madam, Dr. Nigat, Dr. Sheshasai, and Dr. Sri Lakshmi were giving us such wonderful inputs, which all of us need to take home today. And what I would say is, yes, please do offer them the counseling, give them the options, and let them decide. And let us take time to spend some time with these unfortunate couples who come to us, rather than just a cursory checkup and say, go back home, come back next time, let's see. I think we need to spend time. If we don't have time, I'm sure the couple will take time to go to another person who does have time. Let us guide them to go to the right person at the right time so that they have the right outcome. And I thank our expert, Dr. Sampath Kumari, and our chairpersons, Dr. Krishna Sasi sir and Dr. Mahesh Korigal, and all of you for this excellent panel. And I have no words to thank Dr. Rachna and Dr. Shobha for being with me to convene this whole session, and looking forward to much more interesting panels in future. And Chinmayi, I have a small request from our side. I think if you people can just put up a small algorithm like thing which we can send to our general OGCNs for practicing. At least when the patient comes to them with, say, I've had one miscarriage or I've had at least we know where, what, when. A small short thing which we put on a ready reckoner on our table, and we are not in a stage that we cannot log in, we can't tell them come tomorrow. So we could guide them as to where to go and what to do. I think because many of us are not updated on these issues.
No, we will do that.
Good idea.
We will do and give it to
Chinmayi did a wonderful
when to go for exome sequencing, etc.
Chinmayi is there in all the journals and all the books.
We can do it as far.
Yes.
Bharti madam, can I say something?
Yes, Rajeshri, please.
I think this was one of the smartest webinars on genetic and perinatology, with all the smart women being there. And, we are trying to kind of play God by trying to avoid and predict and prevent what can happen. And we are what our genes are, and having an insight so much into what can happen into the genes and how we can modulate, modify, and, try to do good for the general population is really, really a wonderful concept, which we as an obstetrician could take up as a challenge to, decide the kind of population that we are going to have as far as the healthy population is concerned, with no genetic disorders, is what is very important. And such smart women out there, Dr. Sampath Kumari, Dr. Bharti, Dr. Chinmayi, Dr. Oh my God, it's a wonderful session. I thoroughly enjoyed. I rarely sit through all the sessions, but I was all ears listening to everything, every aspect of it, because any amount we listen is insufficient when so far as genetics is concerned, and what to do, the right thing to do at the right time. And as Sampath Kumari madam said, is you offer whatever is there in the basket, and it depends the choice. But still, as Bharti madam has rightly put in, we need to have an algorithm for all the OGs, because that is a larger message we want to convey to the general practitioners, that look, this is what we need to do when we find such and such scenario. And remaining, of course, Dr. Chinmay is there and the others are there to take care, and we just hand over the patients to them for the best possible care. Thank you so much for this wonderful session and accepting right from Srinagar. Dr. Shehnaz, we are coming there to Srinagar in the summer from KSOGA.
Welcome, you're welcome always.
Madam, we can have an executive meeting there.
Oh, sure, definitely.
Always
Yeah,
welcome.
all of you should come with me. That's all. Nobody backing out.
I'm in. Count me in.
Please,
thank you so much.
Always.
I think,
Open arms.
Yes,
this was.
will come. We will come with open arms to hug you. We want to come there.
Bharti
I
madam,
just
can
want
I
to
add
come there
something?
during the tulip festival.
Shobha.
It's such a fantastic show of tulips there in March, April. Srinagar is a beautiful place to see the tulips.
Srinagar
We'll be
is
there.
beautiful always. In summer, winter, autumn, spring, it's always beautiful.
Yeah,
Oh, no,
it
ma'am,
has
we
its
go
Ma'am,
own
you are
to
charm.
all
Amsterdam for
welcome.
the
You are
tulips,
all
but it's such
welcome.
a wonderful tulip garden there, stretching acres and acres, and it's such a lovely sight to see there.
I have seen it in Srinagar. I have been there to Srinagar and I watched seen it.
Nice.
Shobha wants to say something.
Madam, we always tell all these genetic tests are very costly. But the thing is, like, we can refer some patients to Indira Gandhi Institute of Science. They do free of cost exome screening. And there are also some people who are doing research on these genetic things. If we collaborate with them and ask them, they can give it at a very low cost.
Low cost, yeah.
Right.
There are institutes who are doing it. Like even the Thalassemia Association does the testing and the therapy and everything for free. So we need just to connect the dots. We need to connect the dots.
Dr. Chinmay Ratha, what is the concept of doing the screening for thalassemia routinely in all our patients now?
Yes.
Yes, you have to do it.
So what happened was this one of our labs offered us free HPLC with double marker.
Okay.
So we ran it as a pilot project, and in 6 months we found carriers, I mean, not only of thalassemia, but also that HBE trait and HBQ, which can be compound heterozygous situations.
Okay. Yeah.
So
And
that
many
is why
times-
we have made it a routine to do an HPLC for every and it's 200 rupees.
Yeah.
So when I tell the patient, I tell them it's just 200 rupees, just go ahead and do it. And once you explain, I think that was brought about very clearly by Dr. Nikhat, and then the way you explain makes a lot of difference. So we just tell them that once you do this, it's out of our mind, because anemia will happen for any reason and we won't know this. And for that one family which suffers, it is really, really sad. You know, having a child with thalassemia, seeing your child suffer and
Oh,
take a
really?
blood transfusion
Really,
every
really.
2 weeks is not easy.
Thank you so much. Thanks
Yeah.
for clarifying that.
Thank you.
Thank you.
Okay, I think we'll just say bye to each other.
Now the time has come to bid adieu. But again, we will meet again. Alvida na kehna. Alvida na kehna.
Nahi kahenge.
2
All
weeks
the
from
best,
now,
madam.
we'll get back together.
Yeah.
Thank you, ma'am.
Thank you so much.
Thank
Bye,
all of
bye.
you for
Ma'am,
this
for
excellent
getting us
session.
all together. Thank you all.
Thanks.
Thank you, ma'am.
Thank you.
Thank you, Shobha.
Vote of thanks for
Vote of
Sampath
thanks,
ma'am.
Bharti ಮುಗಿಸ್ಬಿಟ್ರು. ಭಾರತಿ ಮೇಡಮ್
Bharti ma'am, ಅದಕ್ಕೆ I am not.
ಇಲ್ಲಿ ನೋಡಿ ಈಗ ನಾನು ನೋಟ್ ರೆಡಿ
Thank you.
ಮಾಡ್ಕೊಂಡಿದ್ದೆ. ಭಾರತಿ ಮೇಡಮ್ ರೆಡಿ.
Thank
Thanks
you.
all kindly.
Can you please propose a formal vote of thanks?
Yeah, no, that's fine. Ma'am, you have
Fine.
done. Thank you so
We
much
are
for
sorry.
getting us all here.
We are sorry for overstepping the time. We'll try to keep it on dot as far as possible from in the future webinars.
Yeah, but if it comes
This was
with a
a
cup of
time
coffee,
well
then fine.
spent, actually.
Yeah. Thank you.
Yeah,
Thank you,
Madam, it was
Looking very
wonderful.
pretty, ma'am.